Good morning, everyone. Hopefully, I'm audible. Please let me know if the audio visuals are clear ones. So, hopefully, you have celebrated your Diwali and still the festivities are going on. So, now, important is, bacho, let's talk about the last part of surgery today. Okay? That is the pancreatico-hepatobiliary system. And along with that, appendix we have to talk about. Great? So, okay. Without any further delay, let's begin then. Let's try to complete the session as early as possible, right? Most probably, I feel in a span of 3 sessions, we'll be able to complete it. Hopefully, if everything remains good. So one session will be up to lunch break. Basically, around 1:15, 1:30, we will take the lunch break. So till that time, after that, there will be 2 more sessions. I hopefully that would be the plan and the outline for today. Clear? Sure. So now if I talk about the next part, beta, that is nothing else but vermiform appendix. Basically, we know that vermiform appendix, which is there, it is a vestigial organ. What is a vestigial organ? The one which does not have any functional value as such, beta. Even if you remove it, that is not going to cause any problem in the body, is known as a vestigial organ. So vermiform appendix, we know it is a vestigial organ. It is a part of your gastrointestinal tract, beta, and it is a blind tubular structure. And where is it exactly present? So I hope all of you are quite aware. It is present, beta, where the small intestine is going to end. That means the ileum ends and the large intestine, that is the cecum, is going to start. That means at the iliocecal junction or the ileocolic junction, beta, we have this blind tubular structure known as the appendix. Now this appendix which is there, it has two parts. The first one you are able to see, beta, this is what is basically the base of the appendix, and this is the apex of your appendix, beta, right? So appendix is a tubular structure having a base and a apex. Important is, beta, ये जो base होता है ना, this base is actually present at the junction of 3 tinea coli. Now what is tinea coli? Tinea coli are nothing else but fibrous bands, beta, which are present in the large intestine or the colon, basically, right? So when you try to palpate these 3 tinea coli, at the junction of these 3 tinea coli, you'll surely find the base of appendix, beta, because sometimes it becomes difficult to identify the appendix, basically, right? So always try to palpate these 3 tinea coli, and at the junction you will find the base. The apex which is there, beta, that apex will keep on changing position. Yes, the apex will be at various locations, beta, in all the individuals, basically, right? There can be multiple locations for the apex of appendix, and on that questions have been even asked in your exam. Okay? Now, as I told you, the base of the appendix which is there, it is going to be constant, beta, in the same location, okay, at the junction of 3 tinea coli, basically. But as I told you, beta, the base is at the junction of 3 tinea coli at the ileocecal junction or the ileocolic junction. But the apex which is there, that apex may vary in the location, beta. Okay. Now, what are the various locations of appendix? Here you can see, beta. First of all, it can be behind the cecum, that is called as retrocecal. It can be besides the cecum, on the sides of the cecum, known as paracecal. It can be below the cecum, beta, that is called as subcecal. It can be towards the pelvic region, beta, that means towards the midline. So here we have the appendix. If it is like this, that means towards the pelvis. It is known as pelvic in position. It can be below the ileum, known as subileal. It can be in front of the ileum, known as pre-ileal, and it can be behind the ileum, known as posterior, beta. Okay? These are the various positions of your apex of the appendix. Now, if they ask you, and this has been a question earlier, which is the most common position of appendix? So do remember, beta, the most common position of appendix is basically behind the cecum, that is called as retrocecal, beta, followed by the second most common position being pelvic. So the most common position of appendix is going to be retrocecal, followed by pelvic. Has to be remembered in your examinations. Okay? Next important, even they have asked in your examination about the least common position. So yaad rakhna, the least common position of appendix which is there, beta, it is going to be post-ileal, beta. Yes, behind the ileum. Post-ileal is going to be the least common position of appendix. Hopefully that's clear to all of you now. Now, when I try to palpate the abdomen of a patient, beta, so during palpation, where I need to palpate for the appendix, basically. So yaad rakhna, beta, for example, if this is the patient's umbilicus, right? If this is the patient's umbilicus, beta, okay, and this is the ASIS of the patient. What is ASIS? Anterior superior iliac spine, right? This is ASIS, that is anterior superior iliac spine of the iliac crest. So, beta, this line which is joining both of them, right? This line which is joining both these structures over here, beta, is basically called as the spino-umbilical line, right? This imaginary line over here is known as the spino-umbilical line. On that spino-umbilical line, you are able to see that 2/3 from the umbilicus, which is right, 2/3 from the umbilicus and 1/3 from the ASIS beta, right? 2/3 from the anterior, 2/3 from the umbilicus basically, and 1/3 from the ASIS. This location which is there beta, this point which is there is known as the McBurney's point. And ये जो McBurney's point होता है, that is what is considered as the location of your appendix. ठीक है? So whenever you want to palpate for the appendix, you have to palpate in the right iliac fossa. Where exactly? 2/3 from the umbilicus and 1/3 from the ASIS beta. This location which is there is known as my McBurney's point in the right iliac fossa. Clear? So that is important to be remembered. Now, next important, if they ask you a previous year question, beta, if they have asked, and that question is, what is the blood supply of your appendix? So we know that the blood supply of appendix is basically by an end artery beta, and that end artery which is there is classically known as an appendicular artery beta. That end artery which is there is known as an appendicular artery, and the previous year question was that this appendicular artery is a branch of which artery? So we know appendix is present at the ileocolic junction, and this junction which is there beta, it is usually supplied by a ileocolic artery. So can I say basically that appendicular artery is an end branch of ileocolic artery? Yes, and that was the question. Okay, so the question was that appendicular artery which is there, this one, this appendicular artery is basically a branch of which artery? The answer has to be ileocolic artery. ठीक है, तो याद रखना, it is actually a branch of the ileocolic artery, and that has been a question, so याद रखो ये बात. Done with that? So that was about the basics. Now let's talk about the condition that is related to the appendix beta, and the condition that we need to talk about is the most common surgical emergency worldwide beta. Yes, worldwide, if they ask me, definitely what is the most common surgical emergency, Dr. Sabha, answer has to be acute appendicitis. Okay, followed by that it could be intestinal obstruction beta. Yes, a lot of people would say hernia. No beta, hernia is usually a elective procedures, basically emergency कम होती है hernia, right? Hernia का emergency is rare, like in strangulated or incarcerated or in obstructed hernias, basically there can be emergency, otherwise it is less common, right? So now let's talk about acute appendicitis. We know appendicitis means infection or inflammation of the appendix, okay, which develops all of a sudden in a very short duration of time beta. That's the reason it is known as acute. So acute appendicitis which is there, it is nothing else but inflammation of the appendix which will be there, and as I told you, it is the most common surgical emergency worldwide also. Okay, now there are basically two types of acute appendicitis beta. One is known as a catarrhal appendicitis. Ab catarrhal appendicitis mein kya hota hai? So do remember that, for example, this is your appendix. In catarrhal appendicitis beta, there is basically a superficial inflammation of the appendix. Yes, so catarrhal means superficial. I hope you might have discussed this. So one is catarrhal inflammation, that is nothing else but a superficial inflammation of the appendix will be seen over here. And the second one which is there beta, which is actually tend to be more common, that second one that you have to remember beta is nothing else but an obstructive appendicitis. The second one is an obstructive appendicitis. Now obstructive appendicitis mein kya hota hai? Understand, in obstructive appendicitis beta, there is basically blockage at the mouth of the appendix, and if the mouth of the appendix usually gets blocked beta, obviously the mucus secretions of the appendix are not able to drain, and if the appendix is not able to drain all these secretions, they will remain collected inside the appendix, and that actually increases the risk of infection or inflammation of the appendix, leading to a obstructive appendicitis. Clear about? So that is going to be more common. Now what could be the causes of that obstruction? So that obstruction is commonly caused by beta something called as a fecalith. What is a basically fecalith? For example, a patient is suffering from chronic constipation, and due to which the patient is having hard stools. Now those hard stools which are there beta, actually there can be formation of a stone out of that hard stool, and the stone that is formed out of the hard stools beta is what is called as the fecalith. So that fecalith can obstruct the mouth of the appendix. Apart from that, it can be any tumors, and the most common tumors of appendix we'll talk about also them, that is known as carcinoids beta. Those can be a cause of obstruction. Even polyps are very common in the intestine, so those polyps can be cause of an obstruction also, right? So yaad rakhna hai baat, obstructive appendicitis, if they ask you what is the most common cause, so we know the most common cause is nothing else but a fecalith. But apart from that, there are other causes. Yes, there are other causes, and those are something like tumors beta or polyps, worm eggs for that matter. Which one? Ascariasis. I hope all of you are quite aware that intestinal ascariasis is very much common, and that can actually be a cause, and even fruit seeds for that matter. ठीक है. If they ask you which is the most common age group in which appendicitis will be seen, beta, so a lot of people usually tend to say definitely that it is children. So please remember, beta, children would be the second most common age group. If they would have asked me that which is the most common age group, beta, so please remember, then my answer would be patients between 10 to 25 years of age. That is usually adolescents or young adults, beta, right? The most common age group which is affected. Now you will see usually people coming from 8th standard, 9th standard, right? That is a very common age of presentation. So 10 to 25 years of age, that means usually adolescents and young adults, beta, are the most common people who are going to present to us with acute appendicitis. Yes, followed by that, it is definitely going to be children, beta, but more common age group is usually the teenagers that come to you. Okay? Now, if they ask you that in case if the acute appendicitis is not treated in time, what is going to happen? Obviously, if it is obstructive in nature, there will be more and more mucus secretion keep on happening. There will be more and more distension of the appendix, and ultimately the appendix is going to rupture. It is going to perforate, beta. When there will be an appendicular perforation, okay, when there is going to be an appendicular perforation, beta, then please tell me definitely which do you think will be the most common organism, which do you think is going to be the most common organism isolated after perforation. So do remember, Viche, that the most common organism that is going to be isolated after a perforation is nothing else but bacteroids. Okay, it is nothing else but bacteroids. Usually you can call it as Bacteroides fragilis also, to be specific. But please remember, beta, that it is basically going to be bacteroids, Viche, followed by the second most common being E. coli. So whenever the appendix is going to perforate, yaad rakhna that it is going to cause peritonitis, as I've told you. And if peritonitis happens, if they ask you which is the most common organism that would be isolated from that peritoneal fluid, then answer has to be bacteroids followed by E. coli. Clear baat? Next important. If they ask you when a patient of acute appendicitis presents to us, what could be the most constant symptom, beta? Most constant means which is always present in every individual of acute appendicitis. So the most constant symptom of acute appendicitis, if they ask you, answer has to be anorexia. Now what is anorexia? Loss of appetite. Barabar? Loss of appetite is known as anorexia. That is the most constant symptom. If they ask you which is the late or uncommon symptom, beta, याद रखना है, late or an uncommon symptom is going to be fever. Yes, reason is, beta, we tend to see that okay, fever is not there, so appendicitis is not there. It's not like that, beta, because fever is going to be sometimes a very late or even an uncommon feature in a lot of individuals. So you should not see that only if fever is present then it could be appendicitis. No, even without fever at times, beta, it could be diagnosed as a case of acute appendicitis. If they ask you that which is the most characteristic symptom now, so if I say most characteristic or most specific symptom to be that, okay, then most characteristic or the most specific symptom is going to be pain. The reason that pain is going to be very much specific, right? How the pain is going to start, understand. The pain will be definitely in the right iliac fossa, beta, or at the McBurney's point, but that pain is actually going to start from the umbilicus. Yes, that pain usually is present in the right iliac fossa, but it radiates from the umbilicus. So now pain which radiates from the umbilicus towards the right iliac fossa is called as a migratory right iliac fossa pain, and this is very characteristic beta for a case of acute appendicitis. So you can write down the most characteristic or pathognomic symptom, okay, for a case of acute appendicitis has to be a migratory right iliac fossa pain. And you have to remember that this migratory right iliac fossa pain which is there, beta, it usually migrates or it usually radiates from which part? It usually migrates or radiates from the umbilicus basically, right? And it radiates from umbilicus due to what reason? Reason is basically, beta, the dermatomal segment or the nerve segment basically, right? Because the nerve segment of the umbilicus and the right iliac fossa is going to be the same. Therefore, the pain usually starts from the umbilicus towards the right iliac fossa. And that was the question, that what is the nerve supply which is going to be the reason for this radiating or the migratory right iliac fossa pain in a patient of acute appendicitis. So yaad rakhna, this pain usually radiates from the umbilicus basically, the reason being a dermatome, and that is called as T10, beta. Okay, ye yaad rakhna, this was a question. So T10 dermatome is the reason why the pain usually radiates from the umbilicus towards the right iliac fossa. Hopefully that's clear to all of you. Now, based on the signs, symptoms, and the findings in a patient of acute appendicitis, beta, also, sorry, based on the signs, symptoms, and the findings beta in a patient, basically, we can suspect that whether the patient is having a chance of acute appendicitis or not, right? Whether there is any likelihood of acute appendicitis or not. Okay, so for that we have to use a score beta, right? So if they ask you that the score that is used, okay, if they ask you that the score that is basically used for the suspicion of acute appendicitis, answer has to be, so yaad rakhna hai, the score that is used for the suspicion of acute appendicitis, the answer has to be a modified Alvarado score. Alvarado was the name of the surgeon. So please remember beta, it is known as the modified Alvarado score beta. Okay. But this modified Alvarado score has generally 8 parameters in it. Okay. Each parameter is given a specific score, and depending on that, how much is the total score of the patient, na? Based on that, definitely we try to see whether the patient is having any chances of acute appendicitis or not. Clear? So this modified Alvarado score which is there beta, it is also known as a Mantel score. ये तो नाम सुना ही होगा. So Mantel score which is there beta, it is basically nothing else but an abbreviation of all those 8 parameters. उन 8 parameters को एक साथ अगर जोड़ दोगे, so that abbreviation becomes Mantel somewhere. So either you call it as the modified Alvarado score or you call it as the Mantel score beta. It's one and the same thing. No issues with this, anybody? So that is important. Now, if I talk about the Mantel score, as I've told you that Mantel's is an abbreviation. So let's see the 8 parameters of the Mantel score beta. So first of all beta, M stands for what? So usually M stands for a migratory right iliac fossa pain bache, and that migratory right iliac fossa pain is radiating from the umbilicus, as I've told you, the most characteristic symptom. This would be given a score of 1. Okay, this is going to be given a score of 1 basically. Next important beta, if they say anorexia, the most constant symptom we have discussed, loss of appetite or anorexia, that is again given a score of 1 beta. Next important, N stands for nausea and vomiting bache. So nausea and vomiting again is given a score of 1. Okay. Then T stands for what? T stands for tenderness in the right iliac fossa. What is tenderness? Pain on palpation. So when you palpate the right iliac fossa, patient has pain over there. So tenderness in the right iliac fossa is given a score of 2 beta because it's somewhat more specific. So tenderness in the right iliac fossa is given a score of 2. Yaad rakhna hai baat. Next, R stands for rebound tenderness. Now what is rebound tenderness? Understand. When you palpate the abdomen, that time the patient doesn't have pain. But when you leave, now the patient has pain beta. Now why this happens? ये क्यों होता है? Reason beta, when you have palpated, maybe that palpation was not so deep that the peritoneum came in contact with the inflamed appendix. But as you left, basically what has happened? The peritoneum started vibrating, and as the peritoneum was set into vibration beta, that peritoneum actually came in contact with the inflamed appendix. And now we know when this peritoneum, which is a pain sensitive structure, that comes in contact with the inflamed appendix beta, now the patient starts to have pain or tenderness. Now this is called as a rebound tenderness beta. We'll also discuss it is known as the Blumberg sign. ठीक है, इसको क्या बोलेंगे? Blumberg sign. So that rebound tenderness which is there is given a score of 1 again. Next important beta, E stands for what? E stands for an elevated temperature. Now what do I mean by an elevated temperature? Fever, right? E stands for nothing else but an elevated temperature, that is fever. That is given a score of 1 beta. Okay, which could be a late or an uncommon feature. L stands for leukocytosis bache. Okay, L stands for a leukocytosis, that is increase in the total leukocyte count or increase in the total WBC count beta, because we know in acute infections leukocytosis is going to happen. So obviously that will be given a score of 2 beta, right? Next important, last one is S for shift to the left. Now what do I mean by shift to left? So CBC will show you that the patient is definitely having leukocytosis or increased TLC count. But in that itself beta, you have to see a DLC, that is the differential leukocyte count. And on that differential leukocyte count, you will be able to see that which WBCs are more. So obviously as it is an acute bacterial infection, therefore the neutrophils are going to be more. But beta, in acute conditions basically, as more neutrophils are required, therefore most of the times beta, you will be able to see immature neutrophils in the circulation itself, right? And these immature form of neutrophils are also known as band neutrophils. You might have heard their name, band neutrophils. So shift to left is nothing else but when there will be more immature neutrophils or band like neutrophils beta inside the circulation. That is given a score of 1 again. Shift to left. Okay? So now याद रखना that each and every parameter of the Mantras or the modified Alvarado score is given a score of 1 except LT beta. Now, what is LT basically? That is leukocytosis and tenderness in the right iliac fossa. These are the only two parameters in the Mantras which are given a score of 2. Rest everything is going to be 1. Now the total score, if you calculate beta, it is going to be somewhere around 10. Right? The total score of the modified Alvarado score beta, okay, or the Mantra score is basically going to be 10. That you have to remember, right? Now, how do we suspect and at what score do we suspect that the patient is having a chance of appendicitis or not? Let's talk about that. So if I talk about the Mantra score beta, ठीक है, तो Mantra score की अगर मैं बात करूं, तो please remember, when do we say that the diagnosis of appendicitis is almost certain beta? Certain मतलब पक्का, almost, right? So please remember, when do we say definitely at what score that the diagnosis of acute appendicitis is almost certain beta कि है ही patient में acute appendicitis? That is said definitely when the score of the patient is 9 or 10. When the score of the patient is around 9 or 10 beta, almost the diagnosis of acute appendicitis is certain. Next, when do we say that the patient is having a high likelihood of acute appendicitis? So we say beta that the patient is having high chance or high likelihood of having acute appendicitis when the score of the patient is either 7 or 8. When the patient score is between 7 or 8 beta, then that is suggestive of a high likelihood of acute appendicitis. Next, when do we say the patient is having equivocal chance of appendicitis? What do I mean by equivocal? Equivocal means 50-50% beta. It may or may not be acute appendicitis. ठीक है? Sorry. So acute equivocal chances of acute appendicitis which is there beta, it is generally seen at a score of around 5 to 6 beta. When the patient score is going to be around 5 or 6, then we say there are 50-50 chances that it may or may not be acute appendicitis. And this is the most important one beta. Reason why this is important, agar now if you send this patient back home, you thought okay, the score is 5 or 6 only, therefore I can send the patient back home. You send the patient back home beta thinking that there is no chance of acute appendicitis. Problem was the patient was actually having acute appendicitis beta, and therefore what has happened, ultimately the patient presented to you later with an appendicular perforation and a peritonitis, therefore, which may definitely be life threatening for the patient as well. Okay, so it's very important that you basically rule out acute appendicitis completely in a patient who is having equivocal score beta. So जब भी patient का score 5 or 6 आता है, so you have to remember one thing, we have to do a CECT abdomen बच्चे. We have to always get a CECT abdomen done even in a child. Okay, so CECT abdomen is done to rule out acute appendicitis beta. Okay, so basically please remember that CECT abdomen has to be done to rule out appendicitis. So CECT may or may not have a role in the other ones beta, but it surely has a role in the equivocal cases. Clear है बात? And the last one beta, when we say definitely there is no chance of or no suspicion of acute appendicitis, when the score of the patient is even less than 5. When the patient score is less than 5 beta, then we say there is no chance almost of acute appendicitis. Hopefully this is clear, very clear to all of you. Chalo. Now in examination, there are various signs beta which could be noted in a patient of acute appendicitis. Let's try to see those signs one by one. The first and the foremost sign, if I talk about beta, is tenderness in the right iliac fossa. Now you can just call it as the tenderness in the right iliac fossa, or we know tenderness is basically more at the McBurney's point. So can I call this as a McBurney's sign? Yes. You may not find this term very commonly, McBurney's sign, as such in a lot of textbooks, because some textbooks tend to use only tenderness in right iliac fossa. But yes, some of them do use this term, that tenderness in the right iliac fossa, which is there beta. It should be referred to as the McBurney's sign. So it's one and the same thing. No issues with this, anybody? Sure. Next important, if I talk about beta, that when we are actually going to palpate the left iliac fossa, then the patient experiences pain in the right iliac fossa. Matlab, understand. For example, I am palpating the patient's left iliac fossa beta, but the patient is having pain in the right iliac fossa. Reason for this, as I palpate the patient's left iliac fossa, all the abdominal organs which are there, they are usually shifted to the right side, and that's the reason beta there is actually pressure on the inflamed appendix. The inflamed appendix which is there now, it is actually getting compressed due to the shift of abdominal organs, and that's the reason the patient may have pain beta, right? So that is classically called as the Rove-Singh sign. Very classical. याद रखना, if there is a tenderness beta that is elicited, okay, tenderness is elicited in the right iliac fossa, but on palpation of what? On palpation of the left iliac fossa. This is classically known as the Rove-Singh sign beta. This is classically known as the Rove-Singh sign. No issues with this, anybody? So that is important to be remembered. Next sign that you need to remember beta is rebound tenderness, as I've told you. Now, what is rebound tenderness? That means when you palpate the abdomen, then the patient doesn't experience pain. But when you leave the abdomen beta, then the patient experiences pain. And this rebound tenderness which is there beta, it is classically known as the Blumberg sign. This is classically known as the Blumberg sign. Hopefully clear to all of you now. This is known as the Blumberg sign beta. याद रखना ये बात भी, ठीक है? Next important is the patient has a pain on coughing. Now what is pain on coughing called as? So when you actually cough when you actually cough beta, that time definitely there is a stretch basically, okay, stretching of the peritoneum and all the other structures, and that may cause pain in the patient. So this pain on coughing is classically known as the Dumfries sign beta, right? The pain on coughing which is there beta, it is classically known as the Dumfries sign. Next important if I talk about is if the patient is having hyperextension of the right hip, okay, hyperextension of the right hip which is there beta, that is causing pain in the right iliac fossa. So yaad rakhna, when we hyperextend the right hip, that leads to pain in the right iliac fossa. Why? What is the location of appendix? This has been a question. Yaad rakhna. What is hyperextension? Understand, this is hyperextension. So when you are going to hyperextend the right hip beta, the patient has pain basically in the lumbar and the right iliac fossa region. This is classically called as the psoas sign beta. Q psoas sign is positive. Reason, the location of the appendix is retrocecal beta, yes, behind the cecum. And when the appendix is behind the cecum, can I say it is actually lying above the psoas muscle, right? The psoas major and the psoas minor muscle. Yes. So that's the reason beta. When you are going to stretch the psoas muscles basically on hyperextension of the right hip, the patient may have pain in the right iliac fossa. That is because of the retrocecal appendix, right? So hyperextension of right hip causing pain in the right iliac fossa, classically known as the psoas sign. Okay, so that has to be remembered. Psoas sign. No issues with this? Can anybody tell me in the chat box? This is a question that I've discussed earlier though. But psoas abscess, if they say beta, अगर एग्जाम में तुम्हारे psoas abscess आ जाता है पिक्चर में या features में, it can be a very close differential diagnosis for which condition of the kidney, anybody? Psoas abscess is a very close differential diagnosis for which condition of your kidney? Let me know in the chat box till that. ठीक है? So hyperextension of right hip causes pain in the right iliac fossa, that is known as psoas sign. Next is the pain on the patient. The patient is having pain beta on the internal rotation of the right hip. Right, the patient has pain on the internal rotation of right thigh basically. So understand what we are doing. We are actually flexing the right thigh of the patient beta. Okay, we are actually flexing the right thigh or the right hip of the patient, and then we are doing an internal rotation. So flexion and internal rotation of the right hip beta is actually causing pain. Reason, the location of my appendix is now going to be pelvic in nature, right? So when my appendix is going to be pelvic in location, obviously when I am going to flex and internally rotate the right hip, my patient is going to have compression of the appendix, inflamed appendix, and that can definitely lead to pain beta. So pain on internal rotation of the right thigh or right hip is classically known as the obturator sign beta. And when is this positive? It is positive when the location of the appendix is pelvic. Okay, so this is basically the obturator sign, another important one. And the last one is beta, that the patient has pain in the epigastrium. Okay, so the patient develops pain in the epigastrium on palpation of the right iliac fossa. Again, due to radiation it happens. So the patient has pain in the epigastrium beta on palpation of the right iliac fossa, and this is classically called as the Aaron sign beta. This is classically known as the Aaron sign. So the three most important ones I've highlighted: Rove-Singh, psoas and obturator. Even Blumberg's is important for that matter. Okay, has to be remembered. So यहाँ पे देख सकते हो what we are palpating. We are palpating the left iliac fossa, but the patient is going to have pain in the right iliac fossa, and this is classically called as the Rove-Singh sign. right? That is important to be remembered. First one. Second important beta here, when you palpate the right iliac fossa, the patient has no pain over here. But when you leave the right iliac fossa beta after palpation, then the patient has pain over here. Okay, then the patient definitely has a pain over here, and this is classically called as the Blumberg sign, right? Rebound tenderness it is. That is important. The other ones which are there, you are able to see the name itself. First is hyperextension of the right hip, and whenever there is hyperextension of the right hip, the patient is having a positive. The patient is having pain, that is called as a positive psoas sign. And psoas sign is positive beta when the location of the appendix is going to be retrocecal in nature, right? Next one which is there, definitely it is flexion and internal rotation of the right hip. So when we do flexion, internal rotation bit of the right hip and abduction of the leg, this is actually going to cause pain beta, and that is known as the obturator sign. And obturator sign is positive and the location of the appendix is going to be pelvic in nature beta. Clear about? Chalo. So that is important. If they ask you now what is going to be the investigation of choice, sorry, investigation of choice which is there beta in a patient, okay, is going to be what? So adult agar hai beta. So if the patient is an adult, then the investigation of choice is going to be a CECT abdomen, as I've discussed earlier also in a lot of abdominal problems. But if they say if the patient is a child beta, in a child you may be able to detect appendicitis beta even on an ultrasound abdomen. So you don't need to go for a CECT further. Okay? याद रखना, investigation of choice for acute appendicitis, for an adult it is going to be a CCT abdo, for a child it is basically going to be an ultrasound abdomen. Clear about? In children, definitely in those cases which we are not able to detect on the ultrasound abdomen, definitely on that condition, in that conditions, definitely we can go for a CCT, but otherwise it's not required. Now what can be the close differential diagnosis for acute appendicitis? मतलब ऐसी कौन सी conditions है बेटा where you may get confused, okay, so between acute appendicitis and this condition. So let's talk about these differential diagnosis of acute appendicitis. The first and the foremost beta, which are non-age specific basically. That means it can be a close differential diagnosis for acute appendicitis in any age group, whether it is a child, adult, or even an elderly patient beta. The first one is bowel obstruction, that is an intestinal obstruction. Obviously, if the patient is having a bowel or an intestinal obstruction, similar features के साथ the patient can present to us in the emergency. Next is ureteric colic. What is ureteric colic? We know beta it is stone inside the ureters in the patient, right? And ureteric colic जब होता है definitely, then I've told you beta that the patient's pain radiates. In kidney stone, the patient's pain is fixed basically in the lumbar region, but in ureteric colic it may radiate. That's the reason it may be confusing. Next important beta, what are the age specific differentials now? If I say beta the patient is a child basically, so now the close differentials would be the first and the foremost can be mesenteric adenitis. What is mesenteric adenitis? It is infection and the inflammation of mesenteric lymph nodes beta. I hope I have told you earlier that mesenteric adenitis beta is a very common condition which happens in a child who is having abdominal TB beta. Yes, abdominal cox जिसमें होता है. So usually the mesenteric lymph nodes which are there, they actually undergo infection and inflammation due to Mycobacterium tuberculosis beta. That's the reason mesenteric adenitis is more likely due to TB. Next important is intussusception, right? If it is a very small child who is presenting to us beta, then we have to also think in terms of intussusception, which can also show similar kind of symptoms. Next important is beta, yes, Meckel's diverticulitis. I have told you in Meckel's itself beta that when the Meckel's diverticulum gets infected and inflamed beta, obviously it will have a very similar symptoms to that of acute appendicitis, right? And that's the reason you always have to see beta that whenever a patient is seeming to be a case of acute appendicitis and the patient gets operated beta, during an operation I've told you a final step is what? I have to pull out beta the proximal 2 feet of the ileum. Why we have to pull out the proximal 2 feet of ileum? To look for any Meckel's diverticulum over there, right? If you are able to see that the Meckel's diverticulum is there and the Meckel's diverticulum appears to be inflamed also, then in that condition you even have to operate for that Meckel's diverticulum, right? If that doesn't happen beta and the Meckel's diverticulum which is there, which is infected, which is inflamed, that remains unnoticed, okay, usko tum dhyan hi nahi dete ho, what is going to happen? Ultimately it may perforate, leading to a peritonitis in the child beta. Clear about? So Meckel's diverticulitis is a very, very important and a close differential of acute appendicitis. Next, if I talk about in adults beta, Adults में the differentials could be something like gastroenteritis beta. Okay, that usually happens after your food poisonings. Next important is a torsion. If it is a young adult male beta, the patient having a testicular torsion. I told you the patient has abdominal pain, nausea, vomiting, fever like symptoms. So it could be a Crohn's differential, or even patients of diverticulitis, right? Elderly patients hai, so they may develop diverticulitis of the colon, which may have similar symptoms. Though you can say that, sir, diverticulosis and diverticulitis is more common in the sigmoid colon we have studied. Yes, I know. But sometimes it may happen in the right side of the colon. Na? And if it happens in the right side of the colon, then it may be a Crohn's differential. Clear hai? Next important beta is females basically. In females में beta, if they ask you what is the Crohn's differentials, one important one is known as Mittelschmerz beta. अब ये Mittelschmerz क्या बात होता है? You might have studied in gynecology. It is nothing else but a mid-cycle pain beta or a ovulation pain, right? So जब भी ovulation होता है, patient has pain in the lower abdomen, that could be a differential. Endometriosis, yes, sometimes we know that ectopic endometrium may be present in the intestine or somewhere in the abdomen, that may have or that may mimic acute appendicitis. Next is PID, pelvic inflammatory disease. We know PID is very commonly seen beta in the fallopian tubes of the female. So it can be a close one, or ectopic pregnancy for that matter. Ectopic pregnancy ka bhi most common site is the fallopian tubes. So that's the reason beta it may have similar symptoms. Clear to all of you now? That is important. Now if they ask you treatment beta, I hope all of you are quite aware that in a patient of acute appendicitis beta, we have to remove the inflamed appendix, right? We have to perform a surgery itself. So the mainstay of management in a patient of acute appendicitis is always a surgery beta. That is nothing else but either we can call it an appendectomy or you can call it as an appendicectomy. Whatever you call it, it is one and the same thing. So appendectomy bol lo, appendicectomy bol lo, it is one and the same. No issues with this. So it can be the treatment of choice over here. Yaad rakhna ye baat. Now, if the patient is not very severely affected, then you can plan it out basically on the next day morning, right? It can be an elective one. But in majority cases, beta, whenever the patient is having acute appendicitis, we tend to take up the patient immediately for an OT, that is for an emergency appendicectomy most of the times, right? Sometimes it could be elective. Now, appendectomy which is there or appendicectomy which is there, it is of two types. Either it can be open appendectomy beta, okay, or it can be a laparoscopic one. The laparoscopic ones are nowadays more commonly preferred because they are minimally invasive, right? Less complications are usually seen after the surgery and an early recovery is going to be there, right? Now, if they ask you, beta, what are the incisions in open surgery for acute appendicitis? What are the incisions that you take, beta, for an open surgery of appendicectomy? Sorry. So, yaad rakhna, the incisions which are taken for an open surgery are going to be, and this have been shown as image based questions in your examination. Okay, so do remember that. Yahan se acha I would show it to you over here. For example, beta, this is the xiphisternum, these are your rib cage, this is basically the abdomen of the patient, right? And this is the umbilical somewhere. We know here we have the ASIS, so and this is the umbilical. So this is the spino-umbilical line, 1/3 from the ASIS and 2/3 from the umbilicus beta. This is what is basically the McBurney's point. So the first incision which is there beta, it is usually done at the McBurney's point, and this is going to be an oblique incision. When you make an oblique incision in the McBurney's point beta, okay, when you are going to make an oblique incision in the McBurney's point, this oblique incision is basically called as the McBurney's incision. ये जो oblique incision करोगे, that is what is known as an McBurney's incision. Now, this McBurney's incision which is there beta, it is actually going to be of two types, right? One is called as the muscle splitting incision. That means once you definitely incise the skin of the patient, then once you definitely incise the fat, then you incise the fascia out there beta, the scarpas and the Camper's fascia would be there. After incising these deep fascia, you will have muscles now, the external oblique, internal oblique and the transversus abdominis. Now what can be done with this muscle? Either you can just split out these muscles beta, or you can basically cut these muscles now, right? If you're just going to split or retract these muscles basically, then it is called as a gridiron incision. Yes, it is a subtype of McBurney's. If you're doing a muscle splitting in McBurney's incision, then it is known as a gridiron incision. Or second one is when you are going to cut the muscles basically. Now when I'm going to cut the muscles beta to go deeper, then that is called as the Rutherford-Morrison incision. Yes, Rutherford-Morrison is basically a subtype of McBurney's. Whenever we do a muscle splitting, muscle cutting McBurney's, that is known as the Rutherford-Morrison. Secondly, beta, in Rutherford Morrison, what is an extra thing that we do? We can actually extend this incision upward and laterally. If you are going to extend the McBurney's incision upward and laterally, beta, that is also called as a Rutherford Morrison incision itself. Okay? The Rutherford Morrison incision may definitely, to have a better surgical view, you can definitely increase the incision upwards and lateral direction, beta. That is what is Rutherford Morrison. No issues with this. This is a Rutherford Morrison extension for that matter, if you can say. Okay, that is important. Next important, if I say beta, if there is any incision that you take in the right iliac fossa itself, beta, but it is a horizontal or a transverse incision and it is 2 centimeters below the umbilicus. So this horizontal or a transverse incision that is seen 2 centimeters below the umbilicus in the right iliac fossa, it's called as the Lanz incision, beta, Lanz. Okay, and this Lanz incision is also known as a bikini incision. Reason it is known as bikini, because beta it will get hidden basically by the undergarments, and that's the reason it is a cosmetically better incision, beta. Clear about? So that is important. No issues with this. I hope you might have studied about other incisions in gynae also. There is a lower abdominal incision in the midline, beta, done for a lower segment cesarean section known as the Phalansteal incision. This is also known as a bikini incision because again it is cosmetically better because it gets hidden. Next important, beta, you might have seen there is an incision in the right upper quadrant or in the right hypochondrium, beta. This oblique incision in the right hypochondrium or right upper quadrant is basically given, beta, for a open cholecystectomy surgery, removal of gallbladder, and that is known as a Kocher's incision, beta, right? That is known as a Kocher's incision. Then this one that you are able to see, beta, is basically a laparotomy incision. Yes, laparotomy incisions which are given, beta, they usually start almost at the level of the epigastrium and ends in the hypogastric region, beta, and these incisions are going to spare the umbilicus. You can see they're not going to cut the umbilicus, beta. So these are the laparotomy midline incisions basically that is given. Clear about? These are the few incisions that you need to have an idea about. Okay, यहाँ पे भी देख सकते हो, the blue one that you are able to see, beta, is known as the McBurney's incision basically, right? Lanz incision which is there basically, beta. Here they have shown it as oblique. It is not oblique, it is basically an horizontal skin incision, beta, which is seen in the right iliac fossa itself, but 2 centimeters below the umbilicus it is going to be seen. That will be a Lanz incision. याद रखना है बात, ठीक है? So that is important. Remember these common incisions that we use. So incisions for open appendicectomy. First, at McBurney's point, beta, if you are going to make an incision, okay. So at McBurney's point, if you have made an incision which is perpendicular to the anterior superior iliac spine, this is basically called as the McBurney's incision. This is known as the McBurney's incision, beta. No issues with this, anybody? So that is important. So if this is the ASIS, beta, you are going to make the incision like this, which is perpendicular to the ASIS basically. So this is the McBurney's incision. Now, if they ask you McBurney's mein, first one is the muscle splitting variety. This muscle splitting subtype of McBurney's is classically known as the gridiron incision, and yaad rakhna in your exam that gridiron incision which is there is the most common incision that we use for appendectomy most commonly. Gridiron is the most common one that we actually use, beta, for the appendectomy surgeries. Nowadays we have also started using Lanz incision very commonly because it gives you a better view basically. Next one is called as the muscle cutting incision, beta. If they ask you what is the muscle cutting incision or muscle cutting subtype of a McBurney's incision called as, then your answer has to be, as I've told you, it is known as the Rutherford Morrison incision, beta. Then you have to remember it is classically known as the Rutherford Morrison incision. Hopefully that's clear. As I've told you already, beta, that Rutherford Morrison incision mein, there is an upward and a lateral extension also that can be done, beta, by cutting the conjoint tendon. So if you can cut the conjoint tendon, bache, okay, so please remember, then upward and lateral extension of the McBurney's incision could be done. That has to be remembered. No issues with this, anybody? That is important. Next important, beta, if I say that at 2 centimeters below the umbilicus, as I told you, beta, at 2 centimeters below the umbilicus, basically a horizontal or a transverse incision that we make is known as the Lanz incision. That is classically referred to as the Lanz incision, beta. That is another one that we commonly tend to use. Here your Lanz incision, as I've told you, beta, it is going to be a transverse incision. Yaad rakhna, horizontal one, it is a muscle splitting incision. So you don't have to cut the muscles over here. You just split the muscles, and it is cosmetically a better incision, beta. Therefore, can be called as a bikini incision also. Clear है? So that is about the incisions that we tend to use in a appendectomy or appendicectomy surgery. Now beta, let's talk about the next one, and that is complications of appendectomy. Shall I? If I talk about complications in appendectomy surgery, which is complications of an appendectomy surgery, the first one which is there, if they ask you what is the most common complication of appendectomy, तो याद रखना है the most common complication of appendectomy surgery is nothing else but wound infection, beta. Right? The most common complication of appendectomy surgery is a wound infection, and I hope all of you are quite aware, beta. There are multiple reasons why a wound infection or a surgical site infection may occur. Right? I've told you. Any infection that happens within the 30 days of surgery is known as a surgical site infection or a wound infection, and it tends to happen, beta, if a proper hand hygiene has not been or proper sterility has not been maintained during appendectomy surgery, or if there has been a splash during the appendectomy surgery, or for that matter after the surgery, beta, the proper dressing of that wound was not done usually. Okay, most of the times it happens in government hospitals, beta, that we tend to do regular dressings of our patients, beta, but sometimes definitely the patient gets ignored most of the times in smaller hospitals वगैरह. That time definitely it may happen as well. Okay, so these are the reasons, and I told you, beta, if the wound infection is going to happen, the sutures are going to break. So a lot of times it happens, beta, that the sutures that are applied after appendectomy, beta, those sutures break, and definitely the patient comes to us with wound dehiscence, beta. Yes, and I've told you wound dehiscence commonly occur between 5th to 8th day after surgery, most commonly 6th day, beta. And I told you when it is seen in the abdomen, it could also be called as a burst abdomen, right? A very common question of your exam. And the patient will have a serosanguinous discharge coming out from the wound, classically known as the salmon fluid sign. A reddish discharge coming out from the wound known as the salmon fluid sign. And what is the emergency management? Definitive management is a abdominal wall closure with proper suturing to be done. But what is the emergency management? Can anybody let me know in the chat box till that time? So that has to be remembered, beta. Now if they ask you what is the most common late complication, so yaad rakhna hai, beta. If they ask you what could be the most common late complication in a patient of a appendectomy surgery, beta, definitely the patient may have strictures at the side, beta, right? Whichever side, once you have removed the appendix now, so you definitely apply the sutures at the base of the appendix. So as you apply the sutures over there, beta, that may lead to formation of strictures basically at the iliocecal junction. So strictures can develop. Okay, next important, if they ask you what could be the other complications in a patient of appendectomy, so it can be hemorrhage. Obviously any surgery, beta, can lead to excessive bleeding or hemorrhage during or after the surgery. The patient may have formation of pus or abscess at that site. The patient may have paralytic ileus. Reason I've told you, beta, most common cause of paralytic ileus or a adynamic bowel obstruction is surgery itself, right? If during an appendectomy surgery you have handled the bowel too much, beta, that can actually lead to it, or even electrolyte disturbances for that matter, like hypokalemia, right? Or portal pyemia, beta, the patient can develop, that is pus which actually reaches up to the portal circulation. Reason, it will go from the iliocecal junction into the inferior mesenteric, superior mesenteric vein, beta, and from the superior mesenteric vein ultimately it reaches up to the portal vein, bache. And the patient may also have development of the fecal fistula also, right? A fistula from which basically the feces are going to drain out. If they ask you which is the most common nerve injury in a patient of acute appendicitis, yaad rakhna hai, the most common nerve injury in a patient of acute appendicitis is known as the ilio-hypogastric nerve, beta. So it is basically a ilio-hypogastric nerve, beta, which is going to be the most common one. That has to be remembered. No issues with this. Now if they ask you, beta, that if the patient is have a, what is the condition, beta, when the patient will have a risk of appendicular perforation. So please remember, whenever the patient's immunity is going to be compromised, beta, right? Whenever the patient's immunity is going to get compromised, those are the conditions when definitely the patient will have a risk of appendicular perforation, right? And if there is a risk of appendicular perforation, do remember that if the appendix perforates, obviously the patient is going to develop perforation peritonitis, beta, right? The patient is going to develop perforation peritonitis, and due to peritonitis, I've told you, the patient may land up into sepsis also, right? That may cause septic shock and even death of the patients at times. That's the reason appendicular perforation is deadly or life threatening beta, right? Appendicular perforation may increase the risk of peritonitis and can land up the patient into sepsis. If they ask you it is common in which patient, so it could be seen in patients who are immunocompromised beta, either very young patients beta, small children, or very old, that is elderly patients beta, or the patients who have been taking high dose of corticosteroid therapy, or the patient who are non-diabetic for that matter. Pregnancy definitely is immunocompromised state बच्चे. Diabetes mellitus is going to be another important condition beta. ठीक है, extremes of ages as I've told you. Okay, next pelvic appendix which is there beta. Okay, तो pelvic appendix अगर है तो pelvic appendicitis अगर है, that is going to increase the risk of perforation and fecal obstruction, because obstructive appendicitis will obviously have more chances of perforation. Now if they ask you what should be the treatment in all these cases wherever we suspect the patient may have a high risk of appendicular perforation, in all these cases beta, the management or the treatment has to be an emergency surgery or an emergency appendectomy. You'll be like, sir, pregnant patients? Yes. This was a previous year question of FMG examination, June 2022, and the question was, a pregnant female comes to your emergency with features of acute appendicitis. What should be the likely step in management? Answer was, options were Auschner-Sherin regime, conservative management, elective appendectomy, or emergency appendectomy. Answer was an emergency appendectomy. Reason, we know that pregnancy is an immunocompromised state, and due to that, the risk of appendicular perforation is very high. And if appendicular perforation happens beta, then not only the fetus is going to die, even the mother is going to die due to peritonitis and sepsis. So what are you going to take are you going to take the risk of surgery? Yes, surely, because at least surgery can save the lives of both. Okay, but if you leave it like that, both the lives are going to be at stake. Clear about? So treatment even in a pregnant female who is having features of acute appendicitis, answer has to be an emergency appendectomy. ये याद रखना है. You tend to do an open appendectomy most of the times, open appendectomy. Okay, no issues with this, anybody? So that is important. Obviously the experienced surgeons definitely who have an expertise, they are only going to operate. The new ones, definitely residents are not allowed to operate in this condition. Okay, clear to all of you now? Chalo. So that is important now. Now next condition beta, let's talk about, and that is nothing else but an appendicular lump. Now why a lump basically forms at the site of the appendix, let's discuss about that. We know beta that appendicitis is nothing else but inflammation, and due to inflammation beta, definitely the walls are going to become too much sticky, right? So what happens if the patient is having acute appendicitis, the appendix and even the surrounding bowel is very sticky beta. Okay, what happens now? Omentum is going to come to fight with the infection. Why? Because I hope you might have studied in anat and physio that omentum which is there beta is basically the lymphoid tissue of abdomen, and therefore it is considered as the policeman of your abdomen. Any infection in the abdomen beta, the first one to fight that is going to be omentum. So that omentum comes to fight that infection, and due to the stickiness of the bowel beta, it actually gets stuck. Okay, it actually gets adhered, it actually gets wrapped around the inflamed appendix beta, and now that leads to formation of an appendicular lump beta. Clear about? So let's talk about the next condition that may arise due to acute appendicitis, and that is an appendicular lump. So whenever they say an acute appendicular lump beta, we know it happens because the omentum which is there, it wraps around the appendix. And why the omentum gets wrapped around the appendix? Basically, reason, as the bowel which is there beta, that usually becomes sticky over here. That means it becomes adherent beta due to the inflammation which is present, right? Now when the patient of acute appendicitis comes to you and you palpate his right iliac fossa, and on palpation of the right iliac fossa, if I'm able to feel the lump, I'm going to suspect that the patient is having an appendicular lump, and in that condition, the treatment is not surgical. Yes. Repeated question, July 2023 FMG again. And a lot of times this has been asked in the examination. People tend to answer it as appendectomy. No beta. Appendicular lump agar hai, so we don't go for an appendectomy immediately. Reason batata ho. Reason is beta because the bowel is too much adherent now, and therefore the omentum which is there, it has got wrapped around the appendix. Now if you have to remove the appendix, you definitely have to separate the omentum properly, and as the bowel is so much adherent now, if you try to separate now beta at this particular point of time, there can be a very high risk of perforation of the bowel. इसीलिए whenever any surface when the surface is very sticky, or adherent at that particular point of time beta, we never go for a surgery immediately, because then if we try to separate those structures, there will be a very high risk of perforation. Okay, that is the reason beta conservative management is going to be the mainstay of management beta in a patient of an appendicular lump. That has to be remembered, and this conservative management is classically called as which regime? So याद रखना है that appendicular lump is usually treated by a conservative regime known as the Ochsner-Schrein regime beta. The name of the regime that is used to treat a case of an appendicular lump is classically known as the Ochsner-Schrein regime. Clear to all of you now? This has been an option in your examination, so do remember that. Clear hai? Now, whenever I say conservative management beta, even in Ochsner-Schrein regime, it is going to be the same thing. That means what? You have to keep your patient NPO, that is nil per oral obviously. Then you tend to give patient IV fluids for the purpose of nutrition. Third, you have to give IV antibiotics because there is a bacterial infection. So you have to give an IV antibiotics in the patient beta. And as the patient is having pain, you should give painkillers, that is analgesics to be given. Clear about? That is important. Now, second thing you have to remember beta, that whenever you are doing a conservative management in a patient of appendicular lump beta, whenever we are actually performing a Ochsner-Schrein regime, one thing that has to be always kept in mind, that we have to continuously monitor the patient's beta. Okay? So what do we have to monitor in the patient? The monitoring of the patient's vitals has to be done. Vitals matlab the patient's blood pressure, pulse rate, and the respiratory rate of the patient, even SpO2 for that matter. These vitals of the patient should be monitored. Secondly, you have to monitor the temperature, the size of the lump, and even the tenderness in the right iliac fossa. These things you have to monitor. Why we have to monitor? Because we have to see that whatever conservative management or the Ochsner-Schrein regime that we have been following, is it actually causing any improvement in the patient's condition or not? ठीक है, वो ठीक कर रही है patient को या नहीं? So first condition, if I say beta, that if the patient recovers, then what we have to do? So याद रखना that if your patient is going to recover, मतलब the inflammation has subsided basically, and that means you have to discharge the patient, right? If the patient recovers, then obviously discharge the patient. क्यों रख रहे हो उसको? And now call the patient after 6 weeks beta. Call the patient usually after a span of 4 to 6 weeks, and then go for removal of the appendix बच्चे. It is known as an interval appendectomy. I have told you that whenever you do surgery after interval of almost 4 to 6 weeks, that is known as the interval surgery. So here we have to go for an interval appendectomy. You will be like, sir, why we have to call the patient after 6 weeks? Why we cannot immediately operate? मैंने reason बता दिया है that even if you give Ochsner-Schrein regime beta, even if the patient's condition improves somewhat, still there is going to be adhesions definitely now, right? If you try to operate, there will be a high risk of bowel perforation. Why to take that chance? Let that inflammation get subsided completely, let that inflammation get resolved completely by giving antibiotics even after discharge, and then let the patient come to us after 4 to 6 weeks and then operate. Clear it? So do not take a chance. If I say beta that the patient's condition, patient's treatment fails, that means even after giving the Ochsner-Schrein regime beta, the patient's condition is not improving, or rather it is worsening. In those conditions beta, then the lump that you were able to palpate in the right iliac fossa was not basically due to the omentum wrapping the appendix. Then it was basically the appendicular abscess beta. Yes, it was basically the abscess that you were able to palpate. So if the patient's condition doesn't improve, that means it is a case of an appendicular abscess beta. And if it is a case of an appendicular abscess, the treatment has to be an extraperitoneal drainage has to be done for the pus, right? You have to do an extraperitoneal drainage for the pus. Obviously, it could be done with the help of a pigtail catheter under an ultrasound or a CT guidance. So extraperitoneal drainage to be done. No issues with this, anybody? So अगर lump है बेटा, तो obviously conservative management known as Ochsner-Schrein regime, but अगर abscess है बेटा, तो extraperitoneal drainage has to be done. That was another important topic of appendix, and the last topic from appendix that we need to talk about, and that's nothing else but the tumors. Yes, let's talk about appendicular tumors now. If I talk about appendicular tumors, if they say the first thing that you need to remember beta, which is the most common appendicular tumor. So do remember the most common appendicular tumor I have told you beta is nothing else but carcinoids, right? The most common appendicular tumor, if I talk about beta, are nothing else but carcinoids beta. And I hope all of you are quite aware that usually the carcinoids develop from the enterochromaffin cells, right? Carcinoids jahan bhi hote beta, they usually tend to develop from the chromaffin or the enterochromaffin cells beta. and that's the reason they are going to be neuroendocrine tumors. Net, if I write beta, that means neuroendocrine tumor I'm talking about. That means a tumor which secretes a neurotransmitter or a hormone like substance. And what is that hormone like substance this carcinoids are going to secrete? They are basically going to secrete excess amount of serotonin. I hope you remember that there was a thyroid cancer beta which was also a neuroendocrine tumor which was secreting excess amount of serotonin leading to serotonin syndrome. That was medullary thyroid cancer beta, right? So similar to that beta, even carcinoids are neuroendocrine tumors which can actually secrete excess amount of serotonin beta leading to serotonin syndrome in a patient. और याद रखना है, in the recent examination there was a history of carcinoids itself which was given in the patient, and they said that the patient is having serotonin syndrome, obviously not directly but indirectly, right? So they said definitely the patient is having a mass which is likely to be a case of carcinoid. The patient was having the features of serotonin syndrome. I hope all of you remember. The features of serotonin syndrome are: it increases GI motility causing diarrhea, it causes flushing, along with that it causes wheezing in the patient, right? These are the features. And they asked you that definitely what should be done for the purpose of diagnosis. So for any condition beta which is going to cause excess secretion of serotonin, we have to look for the metabolite of serotonin beta, or the breakdown product of serotonin in the patient's urine. Obviously the amount of that product will be elevated, and that product is nothing else but, I hope all of you are quite aware, that product was 5-HIAA beta, right? So you had to check for 5-HIAA levels in urine. What is 5-HIAA? It is nothing else but the 5-hydroxy-indole acetic acid levels beta that you have to look for. If these levels are elevated in the urine, that means the patient is having excess serotonin in the body. That means the patient is suffering from serotonin syndrome. That means the mass which is there, but it is something it is some kind of a neuroendocrine tumor. Okay, so hopefully that you are quite aware about. Next important beta, if they ask you now, which is going to be the most common appendicular malignancy beta? अगर कैंसर की बात करें तो please remember the most common appendicular malignancy, if they ask you, answer has to be a mucinous adenocarcinoma. Why adeno? Because we know beta that appendix is basically a part of the intestine which is lined by columnar epithelium, and it is going to secrete excess amount of mucus. So please remember beta that appendix में the most common malignancy or cancer is going to be a mucinous adenocarcinoma. ठीक है? So that is important. You might have heard about a mucinous adenocarcinoma even in the ovaries of a female as well, right? That is the second most common cancer in ovaries. Now if they ask you beta what should be the treatment in the patient of appendicular tumors? Now if I talk about beta, the treatment basically, no, sorry, I have seen the messages now. Emergency appendectomy during second or third trimester would affect the pregnancy? No, it doesn't affect. If you are definitely having an expertise in operating basically, then it doesn't affect. Okay. Next important bit, if I talk about the treatment basically, and that is nothing else but carcinoids ka beta pehle. Now if I talk about the treatment of carcinoids, what is the logic? Understand. For example, beta, this is the ileocecal junction and this is the appendix. Now, if the carcinoid which is there beta, it is less than 2 centimeters in size and it is more than 2 centimeters away from the base, as you are able to see, it is very small in size, and second, it is more than 2 centimeters away from the base. So in that condition beta, we should only go for removal of the appendix. That means we can go for a simple appendectomy beta. Okay, but if that cancer which is there beta, it is definitely, if that carcinoid which is there beta, if that carcinoid is more than 2 centimeters in size, that means it is large in size beta. Secondly, it is within 2 centimeters range from the base, okay, or it is within the 2 centimeters range from the base beta, then you have to go for removal of the complete right side of the colon, right half of the colon. And I hope all of you are quite aware that when we remove the right half of the colon, that is called as a right hemicolectomy, right? That is important beta. So that means you have to remove the ileocolic junction, you have to remove beta the appendix, you have to remove the cecum and even the ascending colon for that matter. Clear about? So do remember that whenever the carcinoid which is there, it is less than 2 centimeters in size beta, and when it is more than 2 centimeters away from the base, in that condition you have to remember beta that we have to go for a simple appendectomy. Then we have to go for a simple appendectomy. Clear about? That is important to be remembered. Next important, if they ask you which is that when the size of the tumor which is there, or the carcinoid which is there, it is more than 2 centimeters in size and it is less than 2 centimeters away from the base beta. In that condition beta, we have to go for a right hemicolectomy, which in that condition we have to go for a right hemicolectomy. No issues with this, anybody? Clear to all of you? Now lastly, if they ask you about the what is the management in a case of malignancy beta. So if I talk about beta, the management in a case of malignancy, okay, that is the mucinous adenocarcinoma. तो याद रखना है बच्चे, in malignancy तो we cannot only remove the appendix, we have to remove the whole right half of the colon. Reason, as the lymphatics and the blood supply of the whole right half of the colon is similar to that of the appendix. Therefore, in a case of malignancy or cancer, there is a very high chance that the whole right half of the colon may be affected. So in a case of malignancy, that is a mucinous adenocarcinoma, you have to go for a right hemicolectomy. One important thing to be remembered beta, that definitely whenever a patient has a mucinous adenocarcinoma beta, that is a malignancy of appendix, the patient can actually develop a complication where the malignancy spreads outside the appendix beta into the peritoneum of the patient. And when the malignancy spreads outside the appendix into the peritoneum, it may also lead to ascites in the patient beta, right? Malignant ascites can develop in the patient. And this condition is classically called as pseudomyxoma peritonei. You might have discussed this in the ovarian cancer known as mucinous adenocarcinoma there. But over there, they might have said that even the pseudomyxoma peritonei may be seen in mucinous adenocarcinoma of ovary. It is the most commonly seen due to an appendicular mucinous adenocarcinoma. Yes, the most common cause of pseudomyxoma peritonei is going to be a mucinous adenocarcinoma of appendix. याद रखना है बात, ठीक है? If they ask you pseudomyxoma peritonei which is there, beta, this complication which is there. Here, what is going to happen? The patient is going to have abdominal distension, beta, as I've told you, due to a massive or a malignant ascites which develops, and the patient may have chances of bowel obstruction also, right? This happens because the cancer is going to spread outside the appendix into the abdominal or the peritoneal cavity. Now, treatment क्या करोगे इसके लिए फिर? If the patient has already developed pseudomyxoma peritonei, you have to do a debulking surgery. Debulking surgery means all the structures wherever the cancer has spread, you try to excise or you try to remove those particular structures. That is known as a debulking surgery, or we can go for a cytoreductive surgery. So please remember, malignant cells have to be removed beta as much as possible. So whichever organs could be removed, we have to remove those. That is debulking or a cytoreductive surgery. And along with that, after that beta, we have to go for a chemotherapy. Reason, there will be some residual malignant cells which will be left in the abdomen. That's the reason we may have to go for a chemotherapy after surgery. You will be like, sir, radio. I've told you beta that on the intestines, if you are going to use a radiotherapy, the patient will have a very high risk of strictures basically due to fibrosis. That's the reason you avoid radiotherapy on the intestine. Clear about? That's important. So that was all about your appendix as well. Now let's talk about the next important part, and that is nothing else but pancreas beta. Hello, let's start now. If I talk about the pancreas बच्चे, तो याद रखना है, if they ask you what is the most common congenital anomaly of pancreas, so I hope all of you are quite aware beta that the congenital anomaly means a congenital defect beta which is present since birth. The most common congenital anomaly of pancreas, a lot of people tend to answer it as annular pancreas. No, it's not annular beta. More common congenital anomaly in a case of pancreas बच्चे is going to be a condition known as pancreas divisum beta. ये जो condition होती है, that is classically known as pancreas divisum. अब ये क्या चीज है? Let's talk about that first. You can write down that the most common condition, that is the most common congenital anomaly of pancreas beta, is nothing else but pancreas divisum. Done with this? Now let's talk about the condition. First of all, let's see the normal pancreas. I hope all of you are quite aware beta that the normal pancreas which is there, it is going to fit like this. It has multiple parts. This is the uncinate process, head, neck, body and tail of pancreas. These are the various parts of pancreas. Now you can see definitely that the head of pancreas which is there beta, it is actually going to fit inside the duodenal C loop beta. ये जो duodenum का C loop होता है ना, इसके अंदर definitely the head of pancreas is going to fit basically. That is important to remember. Pancreas are present in the epigastrium, therefore pancreatitis can actually lead to an epigastric pain. Secondly, pancreas are usually located in the retroperitoneum, that is behind the peritoneum beta. Therefore, that pain of pancreatitis may radiate to the back of the patient as well, beta. Take a lower back of the patient as well. That has to be remembered. Now, pancreas, which is there basically, beta, it has these multiple parts, but basically it has two main ducts, beta. The first main that you are able to see, this is called as the main pancreatic duct, bache, and this is known as the duct of Wirsung, beta. The main pancreatic duct is also known as the duct of Wirsung, which opens in the second part of duodenum, beta, and this area where the pancreatic and the common bile duct opens in the second part of duodenum. This part of duodenum is known as ampulla of Vater, beta. I hope all of you are quite aware. Ampulla of Vater, that is important. Now, that main pancreatic duct or the Wirsung's duct always opens with this green one, beta, and that green one is nothing else but your common bile duct. Yes, so main pancreatic duct opens along with the common bile duct at the ampulla of Vater, and at which papilla? Major papilla, beta. Whereas there is second duct also, beta, and this is called as the accessory duct of pancreas, and this accessory duct of pancreas is also known as duct of Santorini, beta. Okay, this accessory duct is also known as duct of Santorini, and that usually opens again in the duodenum, but at the minor papilla, beta. The opening is smaller over here. Okay, that is important. Now, we know that pancreas are going to have two functions, beta. One is the exocrine function of pancreas. What is an exocrine function? Where the secretion of the pancreas are drained inside the duodenum with the help of a duct, beta, right? The pancreatic ducts. And this is basically, beta, the secretion of the pancreatic enzymes, right? Exocrine function क्या होता है? Secretion of pancreatic enzymes, beta. जैसे कि pancreatic amylase, which is responsible for the digestion of carbohydrates, and second pancreatic lipase, which is responsible for the digestion of fats, beta. Clear about? So that has to be remembered. Second is the endocrine function of pancreas. Endocrine function means definitely, beta, it is basically in the distal part of the body and the tail of pancreas. We have the islets of Langerhans, beta, and these islets of Langerhans are basically specialized group of cells, beta, which are known to produce multiple hormones. Yes. So endocrine function means secretion of hormones by the pancreas, which are directly drained into the blood. Yes, they do not drain by any duct, they directly drain into the patient's blood, beta. And that is done by various islets, various cells in the islets of Langerhans. Jaise alpha cells are known to secrete glucagon, beta cells are known to secrete insulin, the delta cells are known to secrete somatostatin, and the F cells, F for fan. So F cells are known to secrete, beta, sorry, VIP, beta, that is vasoactive intestinal polypeptide, right? That is important to remember. Even in some part of the pancreas, there could be G cells, beta, and those G cells are known to secrete gastrin hormone. These are all the endocrine function of the pancreas, beta. Clear about? So that is important. Brenner's gland, which is there, beta, they usually lie in the duodenum. They are not in the pancreas. Brenner's gland, duodenum, they have the most alkaline secretion of your body, of your GIT. Okay? That is important. Now, pancreas jo hota hai, beta, you have to remember that it is basically formed out of two buds, beta. One is the ventral pancreatic bud and second is the dorsal pancreatic bud. The dorsal pancreatic bud, the larger part, beta, it is always present on the left side of the abdomen. Okay, the ventral pancreatic bud develops on the right side, then it takes a turn, goes to the left side, beta, and then fuses with the dorsal pancreatic bud, and then a normal pancreas are going to be formed in the abdomen, beta. This is what happens basically in the fetal life, beta, or the intrauterine life. But in case, beta, यहाँ पे क्या हो गया कि the ventral pancreatic bud has taken a turn, gone to the left side, but it did not completely fuse with the dorsal pancreatic bud. So if the ventral pancreatic bud, beta, fails to fuse with the dorsal pancreatic bud, then you can see that these ducts are not properly connected, and this condition is basically called as pancreas divisum, beta. यहाँ पे pancreas appear to be divided, na? So this condition is known as pancreas divisum, when the ventral and the dorsal pancreatic bud do not fuse with each other, beta. अब क्या problem होगी? Understand. This major duct which is there, beta, the major duct is formed in the dorsal pancreatic bud, but the opening is in the ventral pancreatic bud. अब problem क्या होगा कि the major pancreatic duct which is there, or the main pancreatic duct which is there, beta, it is not able to open basically at the level of the major papilla. Rather, now it has to open, beta, in the minor papilla of the duodenum. Now, if minor papilla mein problem kya hai? That the opening is very, very small. Now, if the opening is going to be very, very small, do you think that this main pancreatic duct will be able to drain all its secretions properly over here? No. And if the main pancreatic duct is not able to drain all the secretions properly into the duodenum at the level of the minor papilla, all these secretions, all these pancreatic enzymes keep on collecting inside the pancreas. And if there is too much of collection of the pancreatic enzymes inside the pancreas, these pancreatic enzymes, like the pancreatic lipase, will start damaging the own pancreatic fat itself. Yes, वो अपने ही टिश्यू को बर्बाद करना शुरू कर देती है, right? So these pancreatic enzymes beta, they usually start damaging the own pancreatic tissue basically, and that is going to be inflammation of the pancreas known as pancreatitis. So a patient of pancreas disease may be asymptomatic, but in some patients beta, the patient may also have a very high risk of acute pancreatitis as well. Clear about? So that is important to be remembered. So why there is increased risk of acute pancreatitis? I've told you, due to retention of the secretions of the enzymes inside the pancreas. So now, if they say beta pancreas division, this condition which is there, why does it appear? As I've told you, it is due to failure of fusion. Okay, it is due to failure of fusion beta of the dorsal and the ventral pancreatic buds beta. When both the buds do not fuse with each other, that is the reason. If they ask you what is the investigation of choice, here more than the tissue beta, the problem is inside the duct. Okay, the duct has not fused with each other, so इसीलिए duct को देखना है हमें. And I've told you, whenever you have to see any bile ducts beta or pancreatic duct for that matter, the investigation of choice is going to be a MRCP beta, that is a magnetic resonance cholangiopancreatography, which is a T2 weighted MRI of the ducts basically. Over here, as the water appears white or the secretions will appear white, you don't have to inject any kind of contrast or dye into the patient's body, and therefore this MRCP will be a non-invasive investigation. Okay, and therefore it is an investigation of choice. Gold standard, if they ask you for the pancreatic ducts or even for the bile ducts beta, answer has to be ERCP, that is endoscopic retrograde cholangiopancreatography, where we have to insert an endoscope via the patient's oral cavity, go up to the second part of the duodenum, and then we have to go inside the main pancreatic duct or into the common bile duct beta to investigate the cause, right? ERCP जो होता है, it will not only help us in diagnosis but even in the treatment of the patient, but it is invasive in nature. That's the reason it is only considered as a gold standard investigation. Clear about? So that is important. So here the investigation of choice in the patient has to be a MRCP beta to be remembered. Now if they say the patient is asymptomatic, what should be done? I've told you, whenever the patient is asymptomatic, even the patient is not going to come to us. So if the patient is not even going to come to us beta, then to kahe ka treatment? We have to go for only observation of the patient, right? We have to go for an observation in the patient. But if the patient is going to be having high risk of pancreatitis beta, if the patient is having high risk of pancreatitis, in those conditions definitely we need to treat. Now what is the treatment basically? Let's try to understand. So the problem is what beta? That the pancreatic secretions of the enzymes are not able to drain. Why they are not able to drain? Because the opening at the level of minor papilla is very, very small. Can I just widen up this opening? Yes. Normally beta, we have sphincters at the opening of each and every duct beta. Her duct के opening पे definitely there are sphincters. These are muscles which are actually going to control the opening or closing of the ducts basically. So what we do? We do an ERCP in the patient beta. After doing an ERCP, we go up to the level of the minor papilla beta in the duodenum, and over there once we go beta, with the help, now we are actually going to make incisions beta, or we are actually going to make cuts over the sphincters. As we are going to make incisions or cuts at the sphincter at the level of minor papilla, what is going to happen? This opening which is very, very narrow beta, as you make cuts and the muscles at the sphincter are going to relax, this opening is going to widen up. Your opening khul jayegi aur beta, and that is what you want, because if this opening gets wide beta, the pancreatic secretions will be able to drain properly, and that's the reason beta the patient will not have any risk of pancreatitis then. ठीक है, this is a very important thing. Now henceforth याद रखना, बहुत जगह यूज होगी है. This surgery we have performed with the help of ERCP, and second, this surgery is nothing else but making incision over the sphincters to open it up properly. That is called as a sphincterotomy. Clear है बात? चलो. So please remember, if the patient of pancreas division has a very high risk of pancreatitis, then we have to go for a surgery that is called as a ERCP with sphincterotomy beta. Then we have to go for a surgery beta in the patient, and that is known as a ERCP with sphincterotomy. Hopefully that's clear to all of you now. Done with this? Chalo. So ERCP with sphincterotomy has to be done. Let's talk about the next condition beta, which is okay, nothing else but annular pancreas now. Okay, let's talk about the next condition that we need to see, and that is nothing else but annular pancreas. If I talk about annular pancreas in a patient, bache, okay, what is annular pancreas? Annular means ring like. In literal terms beta annular का अगर मतलब समझोगे, it is nothing else but ring like. अब why does this happen? Understand. So in this condition, there is a ring-like pancreatic tissue, as you are able to see, and it is compressing bit, or it is encasing the second part of the duodenum, right, from outside. Why does this happen? Understand? We know beta that the pancreas usually develop from two buds. One is the dorsal pancreatic bud, second is the ventral pancreatic bud. But ये जो ventral pancreatic bud है ना, it is basically a single lobe beta. Okay, it is basically a single lobe which takes a turn from right to the left side and fuses with the dorsal bud normally. ठीक है? यहाँ पे इस पेशेंट में क्या दिक्कत है? That the ventral pancreatic bud which is seen over here beta, it is not one lobe. Basically there are two lobes of the ventral pancreatic bud, right? It is a bifid or a bilobed ventral pancreatic bud. And when there is going to be a bifid ventral pancreatic bud, what can be the problem which may arise? Understand, when this ventral pancreatic bud may be taking a turn towards the left side beta, what is the problem? One lobe of the pancreas, one lobe of the ventral bud beta is going anteriorly, another lobe of the pancreas is going, or another lobe of the ventral bud is going posteriorly. Now one lobe of the pancreas, one lobe of the ventral bud has gone anterior to the duodenum, another lobe of the ventral bud has gone posterior to the duodenum, and now it has fused with the dorsal pancreatic bud. अब जब ये टिश्यू पैंक्रियाटिक टिश्यू फ्यूज हो जाएगा बेटा, नाउ कैन यू सी इट इज बेसिकली कॉजिंग अ कंप्रेशन इन द सेकंड पार्ट ऑफ द duodenum beta, right? So this is basically encasing or compressing the second part of duodenum from outside, and this ring like pancreatic tissue which is formed around the second part of duodenum is basically called as the annular pancreas beta. This ring like pancreatic tissue compressing the duodenum from outside is classically called as annular pancreas. Clear hai? And as the duodenum has been compressed beta, the patient may come to you in the emergency beta. The neonate will be brought to you in the emergency with features of bowel obstruction or the duodenal obstruction beta, right? So that is important, which will be similar to duodenal atresia, right? उसमें भी यही हो रहा था ना, उसमें the difference was that the duodenum was not connected with each other. यहाँ पे the duodenum is connected, but the problem is what? Definitely the duodenum gets compressed from outside. So in both the conditions there is a duodenal obstruction. So annular pancreas is nothing else but malrotation. Okay, it is nothing else but malrotation of the ventral pancreatic bud beta, okay, and fusion with the dorsal bud, which leads to what? Which encases beta, okay, and compresses the second part of duodenum basically beta in that ring like pancreatic tissue. That is called as annular pancreas. And as it compresses the second part of the duodenum beta, obviously it is the cause of a duodenal obstruction, which it is actually going to cause a duodenal obstruction in the neonate. It is going to cause a bowel obstruction or duodenal obstruction in the neonate. If they ask you what is going to be the symptoms, obviously beta, that as the duodenum of the baby is compressed over here, the food will not be able to pass from the duodenum, and that's the reason beta the patient will have a projectile vomiting, because the food will come back now. Okay, so the patient will have a projectile vomiting. If they say beta which kind of vomiting is more commonly seen, तो याद रखना, the second part of duodenum is compressed. We know that the main pancreatic duct or the common bile duct opens into the second part itself. और अगर second part ही बंद है, okay, if the second part is compressed, that means the food is usually coming back from the first part of the duodenum, and the bile does not mix with the food in the first part of duodenum. Bile mixes with the food in the second part, which is compressed over here. यहाँ पे if they ask you that which is going to be a more common type of vomiting, so do remember beta that more commonly it will be a non-bilious vomiting followed by bilious. Yes, in some cases if the obstruction is lesser or obstruction is somewhat distal, then in those conditions bilious vomiting can be a possibility, but more likely it is a non-bilious vomiting. So you will be like, sir, this is how we differentiate. Yes, this can be one of the differentials beta from duodenal atresia, because in duodenal atresia also there is a duodenal obstruction, but वहाँ पे क्या difference था? वहाँ पे there is always a bilious vomiting. Here there is more commonly a non-bilious vomiting. So it can be a close differential for a case of CHPS beta. CHPS, congenital hypertrophic pyloric stenosis. Over there was more commonly a non-bilious kind of vomiting beta. ठीक है? Next important now. If they say what should be the first line investigation, we know beta that first line investigation is nothing else but, anybody? It has to be a CECT abdomen. Why a CECT abdomen? Reason, here we have to check for the pancreatic tissue, and pancreas is a retroperitoneal organ. I hope I have told you in the last urology session itself beta that investigation of choice for all the retroperitoneal problems is usually a CECT abdomen beta, except in Wilms tumor where MRI could be preferred in the early stages, right? Baki jagah to it is always CECT. The first line investigation beta is always a CECT abdomen over here. That has to be done. And on that CECT abdomen, you are able to see that ring-like pancreatic tissue compressing the second part of duodenum. Clear about? Next important, if they ask you beta, if you do an X-ray over here, see, as the patient is coming to us with the intestinal or duodenal obstruction features beta, that's the reason definitely. What are the duodenal obstruction features? Non-bilious vomiting. Okay, and that too mainly at birth it will be seen, right? It will be more commonly seen at birth itself. Okay. And if I do a X-ray, what will be the feature on the X-ray abdomen which will be seen beta? If I do a X-ray of this child beta, sorry, first line investigation will be X-ray abdomen. Investigation of choice is CECT. By mistake I've written. So yaad rakhna, investigation of choice in the patient which is there beta, it is a CECT abdomen. To correct it properly. First line investigation, as I've told you, it is a X-ray abdomen. Now, when I do a X-ray abdomen of the child beta, on that X-ray abdomen, which sign is seen? Anybody? Single bubble, double bubble, triple bubble, multiple bubble. Anybody? If I talk about annular pancreas, what is the sign on X-ray abdomen that is going to be seen? Anybody? X-ray abdomen in a case of annular pancreas, which sign will be seen? Very good. Yes, it is going to be a double bubble sign beta. So yaad rakhna, it is going to be a classical double bubble sign which will be seen over here. Right? I have told you that double bubble sign on the X-ray abdomen beta is usually seen in which conditions? It is basically seen beta in three conditions. The first one was duodenal atresia. The second one to be remembered beta was annular pancreas, and the third one definitely was a case of Lard's band beta, right? These are the three conditions where a double bubble sign on X-ray abdomen could be seen in the patient. Okay? This is another hint to differentiate it from CHPS. Because CHPS maybe the child has non-bilious vomiting, but on X-ray abdomen you are able to see a double bubble sign. In CHPS there is only a single bubble sign which is usually seen. Clear about? Now if they ask you beta, what is the treatment of the patient? So yaad rakhna, here you should not cut the pancreatic tissue beta. Reason, if you are going to cut this ring-like pancreatic tissue, it is actually going to damage the pancreatic tissue beta. And that's the reason definitely it's better that we cut this proximal part of duodenum, we cut the distal part of the duodenum. Matlab, see, you have to cut the duodenum from here, you have to cut the duodenum from here. And now then you are going to join the remaining parts. Obviously, here if you are going to join the remaining parts of the duodenum, that will be called as the duodenal anastomosis beta, or we can call it as a duodenostomy. If the obstruction is too much beta, and now we are not able to connect both the parts of duodenum because duodenum is fixed now. So if the obstruction is too lengthy and therefore you are not able to connect the two parts of duodenum with each other, obviously we know beta, the other option that is available is duodenojejunectomy. But what will be preferred? Same organ with same organ should always be preferred beta, as I've told you. So duodenostomy is always a preferred surgery beta in this patient than basically a DJ-stomy or a duodenojejunectomy. This was the same surgery in duodenal atresia also, right? Duodenostomy. That was all about your annular pancreas as well. Now let's talk about beta the next one. And that next condition that we need to talk about after annular pancreas is done is going to be the sphincter of Oddi dysfunction. Now this has been a question in your exam, that sphincter of Oddi has actually how many sphincters in it? Anatomy and physiology se question hai ye. How many number of sphincters are going to be present in the sphincter of Oddi? Sphincter of Oddi is present in the second part of duodenum at the ampulla of Vater, where basically the common bile duct and the main pancreatic duct opens into the duodenum beta and drain their secretions. So they basically asked in a previous exam that how many sphincters are present in the sphincter of Oddi. Very good. This was a previous question, so do remember 4. So there are total 4 sphincters beta in the sphincter of Oddi together. So ab yaad rakhna. For example, beta, if I say this is the patient's duodenum beta, okay. Now do remember that we are going to have the right and the left hepatic duct coming from the liver, which combines to form the common hepatic duct. It usually combines with a cystic duct coming from the gallbladder, then it forms the common bile duct. And once this common bile duct has been formed beta, we know that the common bile duct which is there, Okay, this common bile duct which is there beta, it is basically going to open in the second part of the duodenum beta. It is basically going to open in the second part of the duodenum beta. Okay, so that is important to be remembered. Secondly beta, along with the common bile duct, we know we also have to see that the main pancreatic duct also opens at the same side beta, right? The main pancreatic duct which is there, it also opens at the same side basically as the common bile duct, and this area which is there beta, this 2 centimeter range from the opening of these ducts basically is called as the ampulla of Vater. ये पूरा जो range है ना, this is what is known as ampulla of Vater beta. Now here you are able to see beta when the CBD, that is common bile duct, and the MPD, that is main pancreatic duct or Wirsung's duct, are opening into the major papilla beta. Here definitely how many sphincters are going to be there? So yaad rakhna beta, the patient is going to have actually 4 sphincters over here. Okay, the first sphincter that you need to remember beta is nothing else but is present at the main pancreatic duct, right? The first sphincter which is there, it is present in the main pancreatic duct beta. Then we are going to have 2 sphincters beta in the common bile duct. Yes, common bile duct में 2 sphincters होते बच्चे. There are 2 sphincters in the common bile duct, and the last sphincter which is there बच्चे, that last sphincter is usually present in the ampulla of Vater itself. Right, the last sphincter is usually present in the ampulla of Vater or the periampullary region itself. So together there are 4 sphincters beta in the sphincter of Oddi. That has to be remembered. Clear about? Now if they say beta that these sphincters are dysfunctional, मतलब ये काम नहीं करते अच्छे से, so obviously beta, if this sphincter of Oddi is going to be dysfunctional, if it is not working properly, please tell me, will these sphincters be able to relax? No. And if the sphincters are not able to relax, will the common bile duct be able to drain its bile? No. And as the bile is not draining, the patient is going to develop an obstructive jaundice or a post-hepatic jaundice beta. Okay. And if there is going to be obstructive jaundice, there will be stasis of bile for a longer duration of time, which can actually increase the risk of infection of the common bile duct. Infection in the bile duct is known as cholangitis beta. Later on, due to extreme stasis of bile for a very long duration of time beta, there can also be a damage of liver also. And if there is chronic damage of liver, I hope all of you are quite aware, it is known as cirrhosis. And if it is due to stasis of a bile beta, then it is known as biliary cirrhosis, right? So over a longer duration of time, if the bile doesn't drain, the patient also may develop a biliary cirrhosis. Next important, if the pancreatic secretions are not able to drain, all the pancreatic secretions will keep on collecting inside the main pancreatic duct and the pancreas. And we know when these pancreatic enzymes collect inside the pancreas for a longer duration of time, they actually tend to cause damage and inflammation of their own cells beta and own tissues. That is the reason beta the patient will develop a high risk of acute pancreatitis in the patient. Clear about? These are the problems beta which can happen due to sphincter of Oddi dysfunction. So when I say sphincter of Oddi dysfunction, do remember that here you have to remember if there is dysfunction beta, what are the problems that may happen? So dysfunction of the pancreatic sphincter, if they say, so if the patient is saying that there is dysfunction of the pancreatic sphincter, if we are able to see that there is dysfunction of the pancreatic sphincter, the patient will have a very high risk of acute pancreatitis, right? The patient will have a very high risk of pancreatitis. That has to be remembered beta. Next important thing, if I say beta that the biliary sphincter is dysfunctional, the biliary sphincter is not working properly, then the patient is going to have a very high risk of cholangitis initially, right? The patient is going to have a very high risk of cholangitis due to an obstructive jaundice. Okay, the patient will have a very high risk of cholangitis due to obstructive jaundice. Later on, the patient may also develop a very severe complication like biliary cirrhosis, right? Later on, the patient may also develop beta a very severe complication like biliary cirrhosis also due to a prolonged or a long-standing obstructive jaundice. The patient may develop biliary cirrhosis. Clear to all of you now? If they ask you beta what is the name of the classification, this was a previous year FMG question beta which came in your examination. Yes, the name of classification for sphincter of Oddi dysfunction they asked basically. That was basically vice versa question. Matlab Milwaukee classification is generally used for which among the following conditions? Answer was sphincter of Oddi dysfunction के लिए use होता है. So do remember that the name of the classifications for sphincter of Oddi dysfunction is going to be called as the Milwaukee classification beta, right? Milwaukee's classification which is there, okay, that Milwaukee classification is generally used for the sphincter of Oddi dysfunction. No issues with this, anybody? Milwaukee's classification is generally used for the sphincter of aortic dysfunction. If they ask you that how many types are there, so please remember, according to Milwaukee's classification, beta, based on the severity of the condition, there are basically three types of sphincter of aortic dysfunction. Grade 1 may definitely the patient is definitely having a problem at the biliary sphincter, beta, due to which there is dilatation of the common bile duct. Along with that, basically the patient has retention of the enzymes. Grade 2 mein beta, the patient only has dilatation of the duct with a dysfunctional sphincter, no retention of enzymes as such basically. Grade 3 mein there is only dysfunctional sphincter, no dilatation, no enzymatic problem. These are the three types of basically the sphincter of aortic dysfunction. अगर वो पूछते हैं कि which is the most common type, just remember most common type of a sphincter of aortic dysfunction has to be a type 1. The most common type of sphincter of aortic dysfunction, if they ask you, answer has to be type 1. It has to be the most common. Okay, the most severe one. If they ask you what is the investigation of choice, तो याद रखना है बेटा that the investigation of choice in a sphincter of aortic dysfunction has to be ERCP with manometry. Yes, MRCP with secretin stimulation can also be used, beta, but better than that basically is a ERCP with manometry, beta. Reason, as the sphincters are not relaxing over here, then in that condition, beta, the pressure at the level of the ampulla of Vater of the sphincter of aorta is going to be very, very high. So to measure that pressure, we have to do a manometry. So we have to do a ERCP with manometry, beta, which will be considered as the investigation of choice. अगर ये नहीं है option में, then the other one that could be used is also, beta, MRCP with secretin stimulation. The other one which is there, beta, it is MRCP with secretin stimulation, could be used also over here. Because that MRCP will definitely show that the sphincters are not the sphincters have not opened up properly. That's the reason the ducts are not able to drain and the patient is having a dilated ducts. Okay, but best one, if they ask you, investigation of choice has to be ERCP with manometry. Next important beta, if I talk about, is treatment in the patient. तो याद रखना है बेटा, treatment के लिए again we have to go with the help of an ERCP, beta, and once we reach at the level of the ampulla of Vater or at the level of sphincters, you have to again make cuts on the sphincters, beta. We have to make incisions on the sphincters. Why? So that the sphincters are able to relax, and as the sphincters are going to relax, beta, these sphincters are going to open up wide properly, and all the secretions which have been retained inside the duct, beta, they will be able to properly drain. And if all the secretions, that is the bile and the pancreatic secretions, are able to drain properly, they will not increase the risk of any problem in the patient, right? So treatment has to be again the same, that is ERCP with sphincterotomy, beta, right? So yaad rakhna hai, ERCP with sphincterotomy is going to be the treatment or surgery of choice in a patient of sphincter of aorta dysfunction. Hopefully that's clear to all of you now. Chalo. So now next important condition, beta. This was all about your sphincter of aorta dysfunction, beta. Once we are done with that, now let's talk about the next condition, and that next condition is nothing else but acute pancreatitis, beta. That next condition that we need to talk about is nothing else but acute pancreatitis. Sorry. If I talk about acute pancreatitis in a patient, bachche, if they ask you that what is going to be the most common cause, so yaad rakhna, most common cause of acute pancreatitis overall has to be gallstones, bachche, followed by alcohol. Yes, most common cause of chronic pancreatitis is alcohol, but most common cause of acute pancreatitis, beta, which develops all of a sudden, has to be gallstones only. Reason definitely, क्या होता है अचानक से? We know that the common bile duct and the main pancreatic duct which is there, beta, they open at the same level in the duodenum, right? So if the patient was having gallstones, one of the gallstone can slip from the gallbladder into the common bile duct, and that stone may come, beta, and it can actually cause obstruction at the opening of these ducts. When there will be an obstruction by the gallstone and the opening of these ducts, again these ducts will not be able to properly drain their secretions, beta. That is actually going to cause increased retention of these secretions inside the pancreas, which can increase the risk of acute pancreatitis in the patient. Clear about? So that is important. So most common cause of acute pancreatitis is gallstones followed by alcohol. This was another important question, that what is the most common cause of acute pancreatitis in children? So yaad rakhna hai bachche, that the most common cause of acute pancreatitis in children is a blunt abdominal trauma, beta. Yes. So yaad rakhna hai beta, that the most common cause of acute pancreatitis in children, small children, is going to be a blunt abdominal trauma. And which kind of blunt abdominal trauma? Usually bicycle handle injuries, beta, right? You might have seen that usually children fall down and they usually hit the bicycle handle over their epigastrium, beta. So that bicycle handle injuries which are there, they are considered as a common cause for a acute pancreatitis in children. This has been a previous year question, beta. याद रखना कि most common cause of acute pancreatitis in children, answer has to be a blunt abdominal trauma. If they ask you, can acute pancreatitis be iatrogenic? Yes, iatrogenic means due to our fault, beta. Yes, it can be iatrogenic in nature as well. So if they ask you that what is the condition where acute pancreatitis is going to be iatrogenic in nature, beta, तो याद रखना है, iatrogenic is due to which procedure? For example, beta, we were doing a ERCP in some patient, and during ERCP, beta, what has happened? By mistake, we have injured the pancreatic sphincter. Now, as the pancreatic sphincter has been injured, there was fibrosis at the level of pancreatic sphincter, beta, and now the pancreatic duct opening is closed, and therefore it is not able to drain the secretions, beta. Right? So, can I say that iatrogenic acute pancreatitis may develop if we have damaged the pancreatic sphincter during a procedure that is known as ERCP, beta, right? So, due to ERCP, basically, the patient definitely may have a risk of developing acute pancreatitis. That has to be remembered. Due to ERCP, it can be seen. Rather, if they say ERCP is actually like due to ERCP, the most common complication of ERCP is nothing else but a pancreatitis which may develop. Okay. Next important is hyperparathyroidism, beta. Hyperparathyroidism में क्या होगा? As there is hyperparathyroidism, the patient will have a hypercalcemia, and due to that, the patient will have increased risk of stone formations. So if there are stone formations, obviously that increases the risk of acute pancreatitis. Next important, hypercalcemia, as I've told you, same reason. Okay. Or even for that matter, hypertriglyceridemia, beta. Hypertriglyceridemia, which is there, it also increases the risk of acute pancreatitis in the patient. Even scorpion bite, for that matter, beta. Scorpion bite is actually an important cause for acute pancreatitis also, and even viral infections for that matter. Apart from all these causes, beta, drugs are also very important and a leading cause of acute pancreatitis. So drug induced pancreatitis की अगर मैं बात करूँ तो याद रखना है that drug induced pancreatitis which is there, it commonly happens due to chemotherapy or anti-cancer drugs, beta, जैसे कि azathioprine, beta, right? Azathioprine, which is a immunomodulator, is a very important cause of drug induced pancreatitis, or even 6-mercaptopurine. So the two important drugs I would like you to remember always, one is azathioprine and the second is going to be 6-mercaptopurine. These are the two important drugs, beta, which are known to be important causes of, beta, acute pancreatitis. Apart from that, thiazides, for that matter, diuretics, they are also going to increase the risk, beta. Okay, apart from that, antiretroviral therapy, yes, usually the drugs you might have heard now for HIV, they are considered as the antiretroviral therapy. In those, beta, definitely you might have heard about the drugs known as navirs, basically navirs, right? So जो navirs होते हैं, definitely all those navirs, indinavir and all of them, ठीक है, ritonavir, indinavir, all of them actually basically increase the risk of acute pancreatitis in a patient. And lastly, all the other chemotherapy drugs may also increase the risk, but the most important ones are azathioprine and 6-mercaptopurine. Okay, so that is the basic causes of your acute pancreatitis. Now, if they say, beta, that acute pancreatitis is going to be more commonly seen in which age group? याद रखना, we know gallstones and alcohol being the most common cause. You have to remember that acute pancreatitis is more commonly seen, beta, in males, first thing, and secondly, it is more commonly seen in middle-aged patients, beta. What are middle-aged or young patients? Usually that is third or fourth decade of life. So you might be able to see, beta, that acute pancreatitis is more commonly seen in third or fourth decade males more commonly than females. Third or fourth decade males are more commonly affected than females, beta. No issues with this. Now, if they ask me that what is the most important and the most pathognomic feature in a patient of acute pancreatitis, so I hope all of you are quite aware now. Pancreas are located in the epigastrium in the retroperitoneum. So obviously, whenever the patient is going to have acute pancreatitis, the patient will have a sudden onset severe, okay, will be a sudden onset and a severe epigastric pain, beta, which is radiating to which part? Which is radiating to the back of the patient, right? So a sudden onset severe epigastric pain, okay, the patient will have a sudden onset severe epigastric pain radiating to the back, beta. This is an important feature to be remembered. Okay, sudden onset severe epigastric pain radiating to the back is classically important beta to be remembered for causing for in a patient of acute pancreatitis. Now, याद रखना है बात that what is going to happen now whenever the patient is going to lie supine beta. Okay, whenever the patient is going to lie supine, what will happen now? Obviously, all the abdominal organs are going to fall on the inflamed pancreas, and as all the abdominal organs are going to compress the inflamed pancreas beta, my patient's abdominal pain is actually going to worsen over here, right? याद रखना, जब भी पेशेंट सीधा लेटता है बेटा, सब abdominal organs का प्रेशर किस पे पड़ेगा? Inflamed pancreas पे, and that's the reason my patient's pain is going to worsen. Secondly, if my patient lies in the prone position, उल्टा लेटता है बेटा पेट के बल, if my patient lies in the prone position, definitely in that condition, now the pancreas are not having any pressure or any compression with the abdominal organs, therefore my patient feels better. Or even when my patient sits bending forwards beta, even when my patient is going to sit bending forwards, in that condition also the abdominal organs are not pressing the pancreas. That's the reason my patient may have pain relief. So sudden onset severe epigastric pain radiating to the back, which is usually worsened beta by lying supine, and it is relieved by either sitting and bending forwards beta. It is usually relieved by sitting or bending forwards, or even in the prone position for that matter. Clear about? Along with this severe epigastric pain in patients of acute pancreatitis, patient may have other features like nausea and vomiting beta. So nausea and vomiting definitely can be the other features which could be present, or even for that matter abdominal distension. Okay, even for that matter abdominal distension could be another important feature to be remembered. In cases of acute pancreatitis beta, if the inflammation spreads further, obviously the inflammation may spread to the left-sided pleura beta, which can cause pleuritis initially and later on leads to a pleural effusion. Okay, so acute pancreatitis as a complication may lead to a left-sided pleural effusion also. Okay, and the patient may develop paralytic ileus. Reason? Because of the inflammation beta, the bowel which the neuromuscular transmission in the bowel which is there beta, it gets affected. And as the neuromuscular transmission in the bowel gets affected, because inflammation spreads over there, that's the reason the patient may have no motility or decreased peristalsis in the intestine, leading to paralytic ileus. Clear about? So that is important. This could be the complications of acute pancreatitis which can happen. Now, the further complications can be beta which are more severe. In a patient of acute pancreatitis beta, the patient may also go into sepsis due to acute pancreatitis. If it is severe enough, the patient may land up into sepsis, and due to sepsis, the patient may land up into MODS. What is MODS? Multiple organ dysfunction syndrome. And as the patient lands up into multiple organ dysfunction syndrome, one by one beta, the organs and the systems of the patient are going to start failing beta. One by one, the organ and the systems of the patient will start failing. Okay, and that is the reason the patient may land up into death also. So the important complications of acute pancreatitis could be multiple organ dysfunction syndrome or even sepsis for that matter. Clear about? So that is important. Now if they ask you beta, what could be the signs in acute severe pancreatitis? So याद रखना है बेटा, if they ask you what are the classical signs in acute hemorrhagic pancreatitis. Hemorrhagic is what? That type of pancreatitis where there is bleeding around the pancreas. And when there will be bleeding around the pancreas, that will lead to hemoperitoneum. And whenever there is hemoperitoneum beta, these three classical signs will be positive. जब भी there will be blood inside the peritoneal cavity or around the peritoneal cavity, the patient will have these classical signs beta which will be seen. First is, you are able to see beta bruising or discoloration in the around the umbilicus. So whenever there is bruising or a discoloration around the umbilicus, that is classically called as a Cullen sign beta. That is classically known as a Cullen sign. Second, whenever there is discoloration of bruising in the flanks beta, so bruising in the flanks which is there beta, it is classically called as a Gray Turner sign. Easy to remember kaise? When you turn, then you are able to see the bruising. ऐसे याद रख लो. So that Gray Turner sign means bruising in the flanks of the patient. And third, bruising in the inguinal region of the patient beta. You are able to see if there is bruising in the inguinal region of the patient. That is classically called as a Fox sign. ठीक है, तो first is bruising around the umbilicus called as the Cullen sign. Second is bruising in the flanks beta called as the Gray Turner sign, and third is bruising in the inguinal region called as the Fox's sign beta. And all of these signs which are there, as I told you beta, all these signs are usually suggestive of hemoperitoneum, that is nothing else but blood in the peritoneal cavity. Can anybody tell me if the patient is having acute hemorrhagic pancreatitis and these signs are positive due to hemoperitoneum? This will be a very close differential diagnosis for which condition of gynae or sorry. It will be a very close differential diagnosis for which condition of obstetrics. Please let me know in the chat box. You should be aware. Very important for your examination. Now, important is beta, when a patient comes to you with acute severe pancreatitis, the symptoms which are there, they may be similar to that of intestinal obstruction, right? Nausea, vomiting, abdominal pain, all of that. That's the reason, or paralytic areas ki wajah se the patient may have constipation, obstipation also. So that's the reason, beta, you tend to do an X-ray abdomen as the first line investigation. And whenever we do an X-ray abdomen in a patient of acute pancreatitis as the first line investigation, these two signs may be visible. Again, I am saying may be visible, not always there. Sometimes it may be present. Now, X-ray abdomen pe kya dikhega? First of all, as the patient may develop paralytic ileus over here, you can see all the gas stays collected inside the bowel or the intestine of the patient's beta. Here you can see there is too much of gas collection inside the jejunum of the patient, and therefore the jejunum of the patient appears to be dilated too much, right? So this dilated or the distended bowel loop that you are able to see in the left hypochondrium beta on the X-ray abdomen is classically called as the sentinel loop sign. ये जो दिख रहा है ना बेटा, the first X-ray which is there, it is basically showing you the classical sentinel loop sign. It is due to a severe jejunal obstruction basically, or say a severe jejunal distension, I would say, right? You are able to see a sentinel loop sign. Next important, here due to inflammation beta or due to paralytic areas, obviously beta, if there is bowel obstruction, the patient will show definitely the air fluid levels on the X-ray abdomen. And when we see the air fluid levels beta, it appears something like this. It appears as if the colon of the patient which is there, it is cut off somewhere due to that air fluid levels. So this is classically called as the colon cutoff sign beta. This is normally or classically known as the colon cutoff sign. Hopefully that's clear to all of you now. So these are the things beta that has to be remembered. This is the classical colon cutoff sign which will be seen. Done. Now important is beta, if they ask you what is this investigation given below, that investigation is nothing else but beta a CECT abdomen biche. Okay, the investigation that is given below is nothing else but a CECT abdomen. And if I talk about CECT abdomen, it is, yes, the investigation of choice radiologically. We know that radiological investigation of choice for all retroperitoneal organs, including the pancreas and pancreatitis, has to be a CECT abdomen. Now when we do a CECT abdomen of this patient beta, okay, so do remember that it is usually done after 72 hours. Yes, it is not done in the initial 72 hours. So you will be like, sir, diagnosis, but a diagnosis ke liye CECT is not necessary. Diagnosis of acute pancreatitis is done by different investigation. I hope all of you are quite aware. Can anybody tell me in the chat box which could be considered as the single best investigation of choice, or the most sensitive test, or the most specific investigation, the best investigation or gold standard investigation? Kuch bhi puche, has to be which investigation overall to diagnose a case of acute pancreatitis in a patient? Let me know in the chat box. So CECT abdomen is not to basically diagnose the case of acute pancreatitis beta. Diagnosis is done by something else. CECT का काम क्या होता है? So CECT abdomen is basically going to tell you the extent or the amount of necrosis that has happened in a patient of pancreatitis. So if you do a CECT very early beta at the time of presentation, then you'll be able to, you are going to underestimate the amount of necrosis. तुम्हें exact necrosis पता ही नहीं चल पाएगा. You will definitely say there is less necrosis, but the inflammation or the necrosis is still going on. It has not stopped yet. That's the reason beta, you have to do a CECT abdomen in a patient of acute pancreatitis usually after the initial 72 hours. Why? To prevent underestimation of necrosis. Otherwise we are going to underestimate the amount of necrosis which has happened basically, right? So to prevent underestimation of necrosis beta, we do it usually after 72 hours. Clear hai baat? So it cannot be the investigation of choice for diagnosis basically. It is just to see the amount of necrosis. Very good. So yaad rakhna beta, pancreatic enzymes are the best way basically to diagnose a case of pancreatitis beta. Pancreatic enzymes will be the best way, right? So if they say gold standard, best investigation, most specific investigation, okay, most sensitive investigation, kuch bhi bole beta, answer has to be pancreatic enzymes. Now there are two types of pancreatic enzymes. It is pancreatic amylase and pancreatic lipase. Which one is more specific? So answer has to be beta, serum pancreatic lipase is going to be more specific. Serum lipase will be more specific than serum amylase. Reason, usually amylase is also present inside the salivary glands beta. Lipase is also present in some amounts in the stomach, but that's very minimal. So serum lipase beta is very much specific basically for a diagnosis of acute pancreatitis. So इसमें भी option हो that whether serum lipase is the better test or serum amylase is the better test. Answer has to be always serum lipase followed by serum amylase beta. Clear है बात? That is important. Next important, now if I talk about the severity assessment basically, that means when a patient of acute pancreatitis, so yaad rakhna, serum lipase which is there or serum amylase for that matter, they are going to show me a 2-fold, 3-fold, 5-fold, even 7 or 10-fold increase beta in their values. Barabar hai? So lipase and amylase values are going to increase multiple times better than the normal value, and that actually gives you a diagnosis of acute pancreatitis. Clear? Now, if they ask you severity assessment, that whether the patient is having a mild, moderate or severe pancreatitis beta, how do you assess that? That can be assessed with multiple scores or parameters that we have beta. Okay, one of them is a Q-SOFA score. Reason, we know that the patients of acute pancreatitis may come to us in sepsis also, and हमें पता है that assessment of severity of sepsis is usually done with the help of a Q-SOFA score or a quick sequential organ failure assessment score. So three parameters we have discussed, definitely GB load or bar, you can remember. Okay, B for systolic blood pressure less than 100 millimeters of mercury. A for altered mental status, which is assessed with the help of GCS or Glasgow Coma Scale. And R for respiratory rate more than 22 breaths per minute, right? So with that Q-SOFA score, you can assess beta the severity of pancreatitis. First thing. Second important, you can even assess the severity beta with the help of second score known as Apache 2 score beta. Apache 2 score, again, it is not very much specific for acute pancreatitis. It is a score which can actually tell us about the severity of that condition or that disease beta in any in any illness basically, right? That is known as the acute physiological and chronic health evaluation beta. It is an acute physiological and a chronic health evaluation score that can be used for any particular illness beta, acute or chronic. Okay, that can tell us about the severity. Next important is known as a CT severity index. This is important. Now, in COVID beta, I hope all of you are quite aware. जैसे COVID में, based on the CT findings of the lungs beta, we used to tell that whether the patient is having a mild, moderate or severe COVID-19. वैसे ही, based on the CT findings beta, our radiologist is going to tell us whether a patient is having a mild, moderate or a severe pancreatitis. And that CT severity index which is there beta is classically known as the Balthazar grading. याद रखना ये नाम, this is important. The CT severity index beta in a patient of acute pancreatitis is known as Balthazar grading beta. Based on the CT findings, a radiologist tells us whether it is mild, moderate or severe pancreatitis. Hopefully that's clear to all of you now. Next important, if they ask you clinical severity score matlab based on the signs and symptoms of the patient beta. Okay, based on the signs, symptoms or the clinical findings in the patient, if you are going to assess the severity in a case of pancreatitis, that is usually done by a score classically known as the Ranson score. A previous year question of your exam, what is that score which tells about the severity of pancreatitis? And answer was Ranson score. So please remember, it is the Ranson score beta, which is definitely the clinical severity score used for a patient of acute pancreatitis. Very important to remember. Whenever the Ranson score of the patient will be more than equal to 3, that is suggestive of acute severe pancreatitis in my patient. Next important beta is Glasgow criteria, which could be used as well. A Glasgow criteria could be used as well. Bishop score can also be used beta. Okay, Bishop score can also be used for diagnosing a severe pancreatitis whenever the Bishop score is also more than equal to 3. Same like Ranson's, whenever the Bishop score is also more than equal to 3, that is suggestive of a severe pancreatitis in my patient. Last is important beta, that is C-reactive protein or C-reactive peptide. We know beta CRP जो होता है, that is C-reactive protein. It is actually an inflammatory marker. Okay, it is a positive inflammatory marker beta or acute phase reactant, which usually tends to increase in cases of inflammation. So obviously, if the C-reactive protein levels are very high, that is suggestive of severe pancreatitis. Very high matlab kitna? So when the C-reactive levels basically beta, they are going to exceed more than 150. Okay, when the C-reactive protein levels are going to exceed 150 milligrams per deciliter beta, obviously that is going to be suggestive of a severe pancreatitis in a patient. No issues with this, anybody? That has to be remembered beta. Clear about? So that is important to be remembered. याद रखना है बात. Next important beta, if I talk about more than 150 CRP level is going to be suggestive of severe pancreatitis. Now this is the criteria that I've given to you beta. You just have to see definitely them once. Okay, they are not going they are not going to ask you completely. Remember the criteria once, you can just read them and that's fine. ठीक है, Ranson's criteria जो होता है बेटा, यहाँ पे you have to see the clinical findings in a patient beta, and that should be assessed at two times. One, at the time of admission into the hospital. Second, after 48 hours of admission beta. On the at the time of admission beta, what you have to assess first, WBC count of the patient more than 16,000 cells per microliter beta. That is considered as one parameter. Next is age of the patient more than 55 years beta. Glucose levels more than 200 milligrams per deciliter. That is suggestive of hyperglycemia in the patient, which can happen due to pancreatic damage. Next, AST levels of the patient more than 250 international units per liter. LDH levels more than 350 international units per liter. Next, within 48 hours of admission beta, you have to see definitely that what are the changes which will be seen. First, if the hematocrit value, that is packed cell volume of the patient, decreases by more than 10%, that is suggestive of a active bleeding in the patient beta. Next, if blood urea nitrogen of the patient is more than 5 milligrams per deciliter, that is suggestive of a kidney dysfunction which can happen, leading to uremia in the patient. Next, serum calcium of the patient less than 8 milligrams per deciliter, leading to hypocalcemia. Arterial PO2 beta, arterial saturation of oxygen, if it falls to less than 60 millimeters of mercury. Normally it is between 60 to 100. Base deficit of the patient is more than 4 milliequivalents per liter beta. That means the patient is actually landing up into metabolic acidosis. Or fluid needs of the patient is more than 6 liters as well. That means the patient is having or going into septic shock. Right? So all of these criteria you have to assess once beta. Next is going to be a Bishop score beta. If I talk about Bishop score, again 1 point each. So B stands for blood urea nitrogen more than 25 milligrams per deciliter. I stands for impaired mental status, CNS involvement, it tells us. S stands for SIRS beta, that is systemic inflammatory response syndrome. We have discussed the features of SIRS beta. I have told you already. Either the patient having hypo or hyperthermia, that is temperature less than 36 or more than 38 beta, or the patient may be having leukocytopenia or leukocytosis beta, that is WBC count either less than 4,000 cells or more than 12,000 cells per cubic millimeter beta, or the patient having a pulse rate of more than 90 beats per minute, that is the mild tachy, or the patient having a respiratory rate of more than 20 breaths per minute beta. Okay, all those features of SIRS, or the patient having an age of more than 60 years, or the patient having any pleural effusions beta. Okay, that is what is classically called as a Bishop score. Clear? So these are the two criteria or scores clinically beta, which can assess the severity of sepsis, which can assess the severity of pancreatitis in a patient. Whenever these scores are more than equal to 3, that is suggested that the patient is having a severe pancreatitis. Now, if they ask you what is the management, I hope all of you are quite aware beta, that the management, the first line management in a case of acute pancreatitis, as the patient, if he is having beta acute severe pancreatitis, obviously, the patient may come to us in the emergency beta in a hemodynamically unstable status at times. Reason, a patient of acute severe pancreatitis may land up into sepsis or septic shock, and that's the reason the patient may come to us in shock or hemodynamic instability will be there. That's the reason the first line management has to be a basic resuscitation beta. The first line management of the patient has to be a basic resuscitation to be done in the patient. Clear about? Now, for basic resuscitation, if they ask you बच्चे that what should be used in the patient, तो याद रखना है बच्चे that the patient has to be given oxygen supplementation if required. Reason, basic resuscitation is what? Airway, breathing, circulation. So if the patient is having respiratory distress, give oxygen supplementation. Next, you have to give IV fluids for circulation beta. IV fluids की अगर मैं बात करूँ, which is the fluid of choice in acute pancreatitis beta? तो in patients of acute pancreatitis beta, we tend to use Ringer's lactate also beta in this patient's. Reason is if the patient is having metabolic acidosis, so Ringer's lactate if we give, that lactate will get broken down and it will release bicarbonates beta, and that's the reason it will cause slight alkalosis. So therefore it can actually help to bring back the pH to normal values beta. So इसीलिए IV fluids में Ringer's lactate can be preferred if the patient is having acidosis beta. So if there is acidosis, then definitely we are going to prefer Ringer's lactate in the patient. If there is no acidosis, then either you can prefer a Ringer's lactate or a normal saline. Both are equally good then. Okay. Next important bit, if I talk about analgesics, if I say analgesics or painkillers will be given because there's a very severe pain in patients of acute pancreatitis beta. That's the reason. Either the patient can be given NSAIDs initially, non-steroidal anti-inflammatory drugs. Okay, but if NSAIDs do not help, like diclofenac, vagara, they do not help, beta. Next, we can also go for opioids in a patient. Opioids are usually drugs like tramadol. Please remember, opioids which are there, morphine and tramadol, they are usually contraindicated, beta, if a patient is having biliary colic. Matlab, if there is obstruction in the bile duct, then in those conditions you should not use opioids. I hope you might have studied that in pharmacology, and that is because there will be a very high risk of perforation beta otherwise. Okay, the pressure in the bile duct increases if you are going to use opioids. So agar bile duct be obstructed hai, and if there's a biliary colic, do not use a opioid in those conditions. Okay. Next important is early initiation of enteral nutrition should be done beta. Yes, as I told you, in patients of acute pancreatitis, for the initial 24 to 48 hours, we keep the patient on parenteral nutrition. We have to give total parenteral nutrition or IV fluids to the patient in the first 24 to 48 hours beta. But after the 48 hours, better to start beta on enteral nutrition, because we know that acute pancreatitis already increases the risk of paralytic ileus. If we are not going to start the enteral nutrition early beta, the risk of paralytic ileus or prolonged paralytic ileus is going to increase. So in those conditions beta, therefore better to start early enteral nutrition. If my patient is able to take the food orally, I should give orally food to the patient. If my patient is not able to take orally, then I have to insert a nasogastric or a nasojejunal tube beta, and then I should give the food. But enteral nutrition as early as possible. Usually after 48 hours it has to be started. Okay. Next important beta, if they ask you definitive treatment in the patient, so do remember that definitive treatment is not surgical beta. Even definitive treatment for a case of acute pancreatitis has to be conservative management itself. Yes, the definitive treatment in a case of acute pancreatitis is only conservative management beta to be done. Now if they ask you definitely what is done in the conservative management, so yaad rakhna beta, the patient has to be kept NPO, that is nil per oral, at least for the initial 24 to 48 hours. I told you, you have to give IV fluids to the patient beta. Okay, crystalloids can be given to the patient. Next important, IV antibiotics have to be given. Now the antibiotics that we tend to give in a patient of acute pancreatitis beta are usually very broad spectrum antibiotics beta, and these broad spectrum antibiotics, if I talk about, is nothing else but antibiotics. Something like meropenem can be given. Okay, we can actually give beta antibiotics like meropenem, right? So एक तो piptas दे दो, that is piperacillin plus tazobactam combination, or you can give meropenem in this patients beta. Clear hai? But very broad spectrum antibiotics are given. Next important is analgesics, that is painkillers to be given in the patient. Clear? So all of this has to be done in the conservative management, which is the definitive management beta in a case of acute pancreatitis. Now, if they say that the cause was gallstone basically for pancreatitis, matlab it was actually a case of a gallstone induced pancreatitis. So याद रखना बेटा, gallstone induced pancreatitis अगर था, तो in that condition you have to see definitely that if the patients of the if the symptoms of the patient are resolving or not. अगर patient के symptoms resolve हो चुके हैं, that means if the patient is improving, that means the gallstone is not there beta, still causing the obstruction. The gallstone has escaped from there. Gallstone निकल गया है वहां से. But in case if the patient's condition does not even resolve after doing the conservative management, patient की condition improve नहीं हो पा रही है. Okay, if the patient symptoms are not resolving, that means the gallstone is basically still there beta at the level of the main pancreatic duct and the common bile duct. So what we have to do, we have to remove the gallstone, and for removal of gallstone, what we have to do, we have to insert an endoscope, that is ERCP has to be done. Once we do a ERCP, go into the second part of duodenum, we turn the scope over there, and then to remove the gallstone beta, first we have to relax the sphincters, because if you are not going to relax the sphincters, you cannot remove the gallstone easily. That's the reason we have to make cut over the sphincters, so that these sphincters are going to relax and the gallstone can be extracted easily beta. So that is known as ERCP with sphincterotomy. So whenever a patient is having a gallstone induced pancreatitis and even after conservative management the patient's condition is not resolving, then we have to do a ERCP with sphincterotomy beta for stone removal. We have to do a ERCP with sphincterotomy for stone removal. Clear about? So that has to be remembered. Done with this. Now second important thing beta, that after you do a ERCP with sphincterotomy for stone removal beta, do remember this, that definitely the patient should undergo a cholecystectomy for before discharge beta, right? जो patient होता है should undergo basically a cholecystectomy before or prior to discharge basically. ठीक है. Reason is, if the patient is having a gallstone induced pancreatitis, matlab there are a lot of gallstones inside the patient's gallbladder, and if the patient is having one episode of acute pancreatitis beta, obviously the patient may develop recurrent episodes of pancreatitis later on if you leave the gallbladder over there. So it's always advisable that counsel your patient that bhai, if you are not going to get treated now, you will definitely have a very high risk of acute pancreatitis later. Now you were saved basically. We are not sure that the next time when you come to us or present to us beta, you will be in the same state, right? So it's better that he should undergo cholecystectomy before discharge, or at least he should get admitted again for a cholecystectomy as early as possible. Okay, so that has to be done. Now if they ask you beta, what are the complications in a case of acute pancreatitis? So do remember the complications that we have to remember for acute pancreatitis will be, first is the acute peripancreatic collection beta. So around the pancreas beta there can be collection. There can be collection of a serous fluid beta due to inflammation, or there can be collection of blood or hemorrhagic fluid. Okay, so it can be any kind of collection beta. So there can be acute peripancreatic collection beta, which is actually a very common complication. Rather, I would say the most common complication of acute pancreatitis. This acute peripancreatic collection which is there beta, we have to drain it properly, right? So we have to definitely do a proper drainage beta of this acute peripancreatic collection, and it can be done with the help of a pigtail catheter. So basically beta, a pigtail catheter insertion and drainage has to be done. A pigtail catheter insertion and drainage has to be done beta. Pigtail catheter is a catheter with this kind of a tail basically beta. It is a twisted or a curved tail. We have to insert a trocar into that catheter. We have to straighten it up, and then after making an incision you have to go with the help of a pigtail catheter beta, and then you have to drain all the pancreas. That should be done under only an ultrasound or a CT guidance beta. Without that you should not go for a drainage beta. So pigtail catheter insertion and drainage has to be done from the peripancreatic collection. Hopefully that's clear to all of you. Now what are the other complications beta which could happen definitely after acute pancreatitis? The other complications can be acute necrotic collection beta. The patient definitely can have a lot of necrotic tissue surrounded around the pancreas beta after an episode of pancreatitis. The patient may have pseudocyst. What is pseudocyst? Now, as the patient had acute pancreatitis beta, there is formation of granulation tissue, and that granulation tissue basically forms a sac around the pancreas, and in that sac that is formed around the pancreas beta by the granulation tissue, in that sac basically of the granulation tissue there is collection of fluid. Now whenever there is collection of fluid beta, we know it is called as a cyst, right? Whenever there is collection of fluid in a sac, that is known as a cyst. But why we are calling it as a pseudocyst? Reason beta, normally when a cyst is formed, okay, the sac is usually lined by a epithelial tissue. Normally जब भी cyst बनता है ना, the sac is usually lined by epithelial tissue. But here I told you the sac is not lined by an epithelial tissue, it is lined by a granulation tissue. That's the reason it is known as a pseudocyst beta, a false cyst. So acute necrotic collection, pseudocyst, ward of necrosis will be there beta. Okay, or the patient will have splenic vein thrombosis also, blockage of the splenic vein which may lead to portal hypertension later. Patient may have splenic artery pseudoaneurysm also beta, due to damage to the splenic artery wall. The patient may develop splenic artery pseudoaneurysms as well. Patient may have SIRS beta, that is features of systemic inflammatory response syndrome. If the acute pancreatitis is not treated, obviously the patient may land up into sepsis as well beta. Due to that the patient may land up into septic shock, or the patients due to sepsis can also land up into ARDS. What is ARDS? Acute respiratory distress syndrome or adult respiratory distress syndrome, which can be a complication of sepsis in the patient. Clear about? So that is important. Let's talk about the one of the complications and then you can take a break. Chronic pancreatitis I'll discuss after break. Now this complication of acute pancreatitis that we have discussed is nothing else but pseudocyst. Yes, but pseudocyst can be a complication after acute as well as a chronic pancreatitis. Okay, it can be a complication after both acute or a chronic pancreatitis beta. So pseudocyst, I have told you, cyst means collection of fluid in a sac, but this time the sac is usually lined by a granulation tissue and not epithelial tissue, therefore called as a pseudocyst. So it is collection of fluid in sac lined by granulation tissue beta after an episode of pancreatitis. Now That episode of pancreatitis can be either acute pancreatitis or a chronic pancreatitis, both. Most common site where the pseudocyst usually forms, beta, you have to remember it is the lesser sac of omentum. I hope all of you are quite aware that in the abdomen we have the greater and the lesser sac of omentum. So in the lesser sac of omentum, beta, there is collection of this fluid usually, okay, around the lesser sac of omentum. Next important, see if the pseudocyst which is there as a complication, it is very common, beta, but in majority cases it is very small in size, therefore it does not cause any pressure symptoms in the patient. Secondly, it gets resolved on its own. Yes, within a span of 6 weeks, बेटा 6 हफ्ते के अंदर अंदर that pseudocyst gets resolved on its own, अपने आप ठीक हो जाता है बेटा. But in some patients the pseudocyst can be bigger in size. It can cause pressure symptoms, beta, because it will start pressing the stomach of the patient, leading to epigastric fullness, pain, nausea and vomiting like symptoms. Or as it is bigger in size, beta, it may not resolve completely, right? Even after 6 weeks, beta, the pseudocyst is going to persist, it is going to remain, right? तो याद रखना, some patients where the pseudocyst is very small in size, those patients will be asymptomatic in nature, कोई symptoms नहीं होंगे. But some patients when the pseudocyst is bigger in size, beta, may develop symptoms like pressure symptoms of epigastric pain will be there, epigastric fullness will be there, nausea and vomiting will be there. These can be the symptoms after an episode of pancreatitis that can be suggestive of pseudocyst in a patient, beta. If they ask you what is the investigation of choice, तो याद रखना, investigation of choice again retroperitoneal collection होगा ये. Therefore, it has to be a CECT abdomen, beta. So CECT abdomen will be the investigation of choice. And when we do a CECT, you are able to see a very classical picture, beta. Can you see the CECT in the next picture? That classical picture is showing you, beta, collection of fluid inside the abdomen, basically in the lesser sac of omentum. This classically is called as a pseudocyst, beta. Can you see such a huge collection of fluid is seen? Okay, so this is a pseudocyst. Now, as I've told you, beta, that majority of the pseudocysts are going to be smaller in size and they are going to resolve on its own. Majority of the pseudocysts which are there, beta, they resolve spontaneously. अपने आप ठीक हो जाते हैं within a span of how many weeks? Within a span of 6 weeks, beta. But there are certain pseudocysts which do not resolve even after 6 weeks or which are causing a lot of problems in the patient, and therefore an intervention or a treatment is required for those. Okay. Now, if they ask you what are the indications for surgical intervention, तो याद रखना, the indications for surgical intervention in a patient of a pseudocyst after an episode of pancreatitis will be, okay, rule of 6 has to be followed, beta. एक rule of 6 follow करना है अपने को. What is that? First, if the cyst is more than 6 weeks old, beta. Second, if the size of the cyst is more than 6 centimeters, beta. If the size of the cyst is more than 6 centimeters. Third, the wall thickness of the cyst is more than 6 millimeter. The wall thickness of the cyst is more than 6 centimeters. So if the cyst is going to be more than 6 weeks old, if the cyst is more than 6 centimeters in size, or if the wall thickness of the cyst is more than 6 millimeters, these are the indications, beta, where you have to operate the cyst, beta. Okay, or when we have to go for a intervention in the cyst. Sorry, the intervention which is there, beta, it is nothing else but drainage we have to do, right? So please remember the intervention which is there, बच्चे, is nothing else but drainage of the fluid that has to be done in the cyst. And ये जो intervention है basically of the drainage that we do, it can be of two types. Either it can be internal drainage or an external drainage of the cyst. If I talk about an external drainage, मतलब बाहर से drain करना है cyst को, कैसे? Under ultrasound or CT guidance, बेटा, we have to insert the same catheter. कौन सा catheter था वो? It was the pigtail catheter, beta. And under ultrasound or CT guidance, once you insert the pigtail catheter inside that pseudocyst, you are going to drain all the cyst, beta, by aspirating all the fluid completely from that cyst. Clear hai baat? So external drainage which is there, beta, it is done with a pigtail catheter. So pigtail catheter insertion, pigtail catheter insertion and drainage has to be done, bache, under ultrasound or CT guidance. Usually a CT guidance, but can be done under ultrasound also. So under a ultrasound or a CT guidance. So pigtail catheter insertion and drainage of the cyst has to be done externally, beta. So that is done under a ultrasound or CT guidance. Okay, so that is important to remember. So pigtail catheter insertion, beta, and drainage has to be done under ultrasound and a CT guidance. This is the mode of external drainage of the cyst, beta. This is the mode of external drainage of the cyst that has to be remembered. Now external drainage कब करते हो बेटा? External drainage is usually done when the cyst which is there, it is either infected or if there is bleeding inside the cyst. बराबर है? That means if there is either infection inside the cyst beta, or if there is any kind of hemorrhage inside the cyst, then in those conditions definitely these are the two indications when I can go for an external drainage basically. Otherwise, if these problems are not there beta, we can go for internal drainage of the cyst also. Agar if there is infection or hemorrhage within the cyst, then we have to go for a external drainage beta, because we cannot drain the infected or the hemorrhagic fluid into the patient's GI tract. ठीक है, बट अगर ऐसा कोई दिक्कत नहीं है, there is no infection or there is no hemorrhage, then we can even go for internal drainage. Internal drainage of the cyst is done in which manner? Understand, for example, अगर ये patient का stomach है बेटा, and this is the patient's duodenum or the jejunum over here. ठीक है, तो अगर duodenum है या फिर यहाँ पे jejunum है, and here definitely there is collection of fluid beta, there is a cyst over here. Either we can open the cyst into the stomach of the patient, that will be called as a cystogastrostomy, or we can open the cyst into the intestine of the patient, which is known as cystoenterostomy beta, or we can even call it a cystojejunostomy wherever we open it. ठीक है, so that can be internal drainage. So internal drainage can be either be a cystogastrostomy or a cystoenterostomy. Cystoenterostomy is more commonly performed, and it has also been given in your examinations as an option in a previous year question beta. So cystoenterostomy or a cystogastrostomy can be done laparoscopically also, you can do it beta. So an internal drainage of the cyst can be done either into the intestine or the stomach of the patient, known as cystoenterostomy or cystogastrostomy respectively. Clear है बात? That is important. If they ask you what can be the complications beta, तो याद रखना, the most common complication of a pseudocyst, the most common complication of a pseudocyst will be infection followed by hemorrhage. The most common complication of the pseudocyst which is there beta, it is infection of the pseudocyst due to collection of fluid for a longer duration followed by hemorrhage beta. This has been a previous year examination question. You need to remember. Clear about? So that is important to remember. These are the important things about the pseudocyst that we have to remember, and this was the complications of acute pancreatitis also. Now let's take a lunch break, and after lunch break definitely, okay, 15 minutes of lunch break, and after lunch break we'll be discussing about the remaining topics, that is chronic pancreatitis will be there. Along with chronic pancreatitis, we have to discuss about pancreatic cancer and the neuroendocrine tumors of pancreas. These will be the three parts of pancreas left. And once we are done with pancreas, then we will be talking about the liver beta. Okay? In liver, definitely we are going to talk about the normal anatomy of liver and the infections and abscesses of liver, along with the liver tumors as well. Okay? So once we have discussed the liver tumors and the liver cancer beta, uske baad, then we have to talk about the gallbladder beta. Okay, then we have to talk about basically the gallbladder and the bile ducts as well. Okay, sure. Chalo bachcho, now let's start. Hopefully all of you are back. Let me know once if the audio visuals are clear and we can proceed. Now in this session we'll be talking about chronic pancreatitis and all the types of pancreatic tumors along with liver. Okay? Let's start now. So next topic is chronic pancreatitis beta. We know that pancreatitis is inflammation of the pancreas. We have discussed about acute pancreatitis, where the patient presents to us in the emergency beta with very severe signs and symptoms. But in chronic pancreatitis, the patient may present to us in the OPD beta with mild to moderate signs and symptoms usually, because it is a long-standing inflammation. And we know that whenever there will be a chronic inflammation beta, the damage and the repair will go hand in hand simultaneously, right? That means if there is inflammation of the pancreas, at the same time, beta, there will be fibrosis in the pancreas also for the purpose of repair. Clear? That is important. So we have to remember chronic pancreatitis, it is a sequel, means a complication of acute pancreatitis beta. If acute pancreatitis is left untreated beta, it can develop into chronic pancreatitis. Okay? And in chronic pancreatitis, as I told you, it leads to fibrosis in and around the pancreas beta. If they ask you what is the most common cause of chronic pancreatitis, we discussed it already. That is nothing else but alcohol. The most common cause of acute pancreatitis was gallstones followed by alcohol. But the most common cause of chronic pancreatitis has to be alcohol itself. Now, please remember all the causes of all the causes of chronic pancreatitis beta, they are usually classified under a classification, and that classification for chronic pancreatitis is known as the Tigar-O classification beta. You have to remember the classification which categorizes or classifies all the etiologies or all the causes definitely of chronic pancreatitis is classically called as the Tigar-O classification. Now, when I talk about the Tigar-O classification beta, you have to remember one thing. T usually which is there, it stands for toxins beta. And we know toxins, what are the toxins basically? One toxin is obviously going to be the alcohol, and the other toxins can be drugs, right? So some medications which are there, drugs, definitely they can be the cause. So alcohol and drugs are the reasons for a chronic pancreatitis beta. Another, I stands for idiopathic beta, that is unknown causes. G stands for genetics. There can be certain gene mutations which can be associated with chronic pancreatitis. A stands for autoimmunity. That means there can be autoimmune destruction of the pancreas as well. R stands for recurrent cases, and O stands for obstruction. Obstruction means something like a gallstone. But here the gallstone may not be causing a complete obstruction, and that's the reason it is causing chronic pancreatitis instead of an acute one. Okay? Next important, if they ask you what will be the clinical features in a case of a chronic pancreatitis. I hope all of you are quite aware now. If there is chronic pancreatitis, I have told you there will be a long-standing inflammation, and due to that there will also be fibrosis in the pancreatic tissue. So due to that beta, the pancreatic tissues will get damaged over a period of time. Therefore, the patient will have loss of function of the pancreas beta. We have discussed already there are two types of function in the pancreas. One is the exocrine function, which is secretion of the pancreatic enzymes required for the purpose of absorption, and second definitely beta is the endocrine function of pancreas, where the pancreas are going to secrete some hormones, right? So please remember beta, if I talk about first of all, the problem can be an exocrine insufficiency. Exocrine insufficiency means there will be deficiency of the pancreatic enzymes beta, which are required for digestion. Now, if there is deficiency of pancreatic enzymes like the pancreatic lipase or pancreatic amylase beta, due to that the patient will have malabsorption of definitely the fat and the carbohydrates respectively. When the patient is going to have fat malabsorption beta, as pancreatic lipase will not be there, the patient will not be able to absorb fat properly, and that's the reason fat malabsorption which is there, it will lead to what problem now? Here the patient will have failure to thrive. What is failure to thrive beta? The patient will not be able to gain the weight basically. That can be a problem. And second most important problem beta is all the fat which is there, it doesn't get digested from the diet. Therefore all the fat is excreted out in the patient's stools or the patient's feces beta. Yes, and therefore the patient will have a very greasy, bulky, foul-smelling stools, beta. And these greasy, bulky, foul-smelling stools are basically called as steatorrhea. So this has been a previous year question of your exam. याद रखना है बता that steatorrhea which is there. Steatorrhea is definitely a feature of fat malabsorption, and that steatorrhea which is there, it is nothing else but greasy, bulky, foul-smelling stools, beta. So greasy, foul-smelling stools which are there, that is what is classically called as steatorrhea, which you have to remember. The greasy, foul-smelling stools are known as steatorrhea. It is due to excretion of fats basically inside the patient's stools, beta, due to fat malabsorption. Next important feature will be due to carbohydrate malabsorption, beta. If the carbohydrates of the patient are not absorbed, reason is definitely there is deficiency of the pancreatic amylase, and as the carbohydrate of the patients are not absorbed properly, beta, the patient is going to develop problems like what? See, these carbohydrates which are there, the sugars will remain inside the patient's intestine, beta, and when these carbohydrates will not get absorbed, they will remain in the intestine of the patient. The intestinal bacteria which is there, beta, it is going to ferment the sugars, and due to that there will be release of a lot of gas. So the patient will have a lot of gas production in the intestine, beta, leading to bloating. Okay, in the patient, the patient definitely has a lot of gas leading to bloating. That has to be remembered. Apart from that, beta, the patient may also have an osmotic diarrhea as well, beta. The patient over here, due to carbohydrate malabsorption, that sugars which are there, or that carbohydrate which is there, beta, it may attract a lot of water into the intestine, leading to an osmotic diarrhea. So bloating or flatulence along with osmotic diarrhea, nausea, vomiting like features, they are seen due to carbohydrate malabsorption in this patient. That was about the exocrine insufficiency. Now let's talk about the endocrine insufficiency. If I talk about the endocrine insufficiency, beta, in the patient, we know there will be deficiency of multiple hormones which are secreted by the pancreas, but other hormones have an option. For example, glucagon, if I talk about, beta, glucagon is a hormone which is known to increase the blood glucose levels. But even if glucagon is not present, beta, other hormones like cortisol, growth hormone, they also have similar functions, so they may take over. But problem is, beta, there is only one hypoglycemic hormone in the body which is known to decrease the blood glucose levels, and that is insulin. So if insulin is not going to be produced, beta, there is no other hormone in the body which can do the same action to decrease the blood glucose levels. So that's the reason if the patient's pancreas will get damaged, beta, especially the beta cells will get damaged, patient will develop endocrine insufficiency, that is deficiency of insulin will be there. And due to deficiency of insulin, beta, patient will have high blood glucose levels or hyperglycemia, leading to diabetes mellitus in the patient. Clear about that? Has to be remembered. No issues with this. So do remember this. Apart from that, beta, what can be the other features in the patient? Sorry. The other features in the patient, beta, the patient is going to have mild to moderate pain basically. That has to be remembered. The patient is going to have, beta, mild to moderate pain. That has to be remembered. Apart from that, the patient will have an ineffective drainage, beta. The patient is also going to have an ineffective drainage, and as the pancreatic secretions are not able to properly drain, beta, from the main pancreatic duct, there will be stasis of the secretions in the pancreatic duct, and if there is stasis of the secretions inside the duct, beta, there will be increased risk of stone formation, right? So as there is ineffective drainage of the pancreatic secretion, that leads to stasis of the secretions in the main pancreatic duct, and that will lead to formation of stones in the main pancreatic duct, beta. Clear hai? So stone formation ka risk is going to increase as well. Investigation of choice, if they ask you, beta. Now see, if I have to see any problem in the duct, if the problem of chronic pancreatitis is in the duct, beta, then obviously I have to do a MRCP. But if the problem of the chronic pancreatitis is inside the tissues, then I have to go for a CECT abdomen. Clear hai? So investigation of choice, if the problem is related to ducts, it can be MRCP. Okay, but and when you do an MRCP, beta, you are able to see a very classical feature. Why? Because when I do an MRCP, I'll be able to see that the pancreatic secretions have not drained properly, and due to that, the pressure inside the main pancreatic duct is increasing, and due to that, beta, the main pancreatic duct dilates, and as the main pancreatic duct dilates, beta, it starts looking like this. It actually starts looking like a chain of lakes. This is a very classical appearance, beta, that is seen in the MRCP picture in a case of chronic pancreatitis. So if they say that MRCP is showing you a chain of lakes appearance, beta, that is very classical of chronic pancreatitis in a patient. Okay? That is very classical of chronic pancreatitis in a patient. That has to be remembered. Apart from that, beta, as I told you, if the problem or the defect is in the tissues, then you have to go for a CECT abdomen. If the problem or the defect is in the tissues, beta, then we have to go for a CECT abdomen. That has to be remembered. Now, if they ask you what is going to be the gold standard investigation, so yaad rakhna, we know beta MRCP if it is investigation of choice. Okay, ERCP will be the gold standard investigation. Reason is ERCP will not only help us in making the diagnosis, but it can also help us in treatment. For example, if there is any obstruction in the main pancreatic duct, ERCP can actually help us to remove that obstruction also. That's the reason ERCP will be considered as a gold standard investigation beta for a case of chronic pancreatitis. Okay, but if they ask you beta that what is the most sensitive investigation for these ducts, whether it is bile ducts beta or the pancreatic duct, if they ask you what is the most sensitive investigation for the ducts beta, answer has to be a nuclear scan, and that is classically known as the HIDA scan beta. याद रखना, the most sensitive investigation for all your ducts is going to be HIDA scan. HIDA scan is nothing else but hepatic immunodiacetic acid scan beta. Okay, it is the most sensitive investigation for all the ducts. Okay, clear to all of you now? So that is important beta about the diagnosis or the investigation. Now here you are able to see beta, this is a CECT abdomen of the patient. On that CECT abdomen, we are able to see beta, these are nothing else but the stones, right? So we are able to see stone formation inside the main pancreatic duct beta. Okay, in the pancreas you are able to see all these stones have been formed due to stasis of secretions bache. Okay, so these have, that has to be remembered beta. Here you are able to see stones in the MPD. MPD is main pancreatic duct. Clear about that is important beta. And this is the MRCP picture beta, and on the MRCP we are able to see classically what is seen on the MRCP. Obviously MRCP I have told you is a T2 weighted MRI, therefore all the secretions are going to appear white beta even without injecting a contrast. That's the reason here you can see the pancreatic duct appears white, and can you see it appears to be dilated here. Okay, the main pancreatic duct of the patient appears dilated over here, giving this classical chain of lake appearance, right? Giving this classical chain of lakes appearance beta. Clear about? Chalo. So that is important beta. These are the things that you are going to see over here. Now if I talk about beta, the next one, that is what is the treatment in the patient. So hopefully you are quite aware that the treatment in a patient of chronic pancreatitis is again conservative. You don't initially go for a surgical management directly if there is no indication. Okay, so what is the mainstay of management initially? When you start the treatment in a case of chronic pancreatitis beta, you usually start with analgesics. Painkillers are going to be the first choice to be given, because the patient most of the times, but in majority cases, comes to you definitely with what? Comes to you with a mild pain or mild to moderate abdominal pain beta or epigastric pain. So analgesics have to be given. If the patient does not respond to it beta, then if the patient does not respond to the analgesics only, then we have to go for a surgical intervention in the patient. Okay, then we have to go for a surgical intervention in the patient. And now if I talk about surgical interventions, let's talk about them beta. Okay, but along with surgical intervention, one thing that we have to keep in mind, see, we have to continue analgesics in the patient because the patient is going to have pain for some time. But apart from that beta, in the definitive treatment, apart from the surgical intervention that we are going to do, along with that beta, we have to add two more things. And what are those two more things beta? One definitely is going to be, one definitely is going to be beta, a pancreatic enzyme supplementation, right? You have to remember one thing that you have to remember is a pancreatic enzyme supplementation. Reason, as the patient is having deficiency of pancreatic enzymes, that's the reason the patient is having all those malabsorption symptoms. So to overcome that, you have to give pancreatic enzyme supplementation beta. Okay, apart from that, definitely you can also give OHA beta. What is OHA? I hope all of you are quite aware. Oral hypoglycemic agents beta. That is drugs like metformin vagara, which are used to treat diabetes mellitus or hyperglycemia in the patient. Or even if the patient does not only respond to OHA, then you can also give insulin injections in the patient as well. Okay, so definitive management mein beta, we have to go for a surgical intervention, but alongside we have to take care of some more things. We have to give painkillers or analgesics for pain relief. We have to give pancreatic enzyme supplementation for the exocrine insufficiency, and we have to give oral hypoglycemic agents or insulin for the endocrine insufficiency or diabetes. Okay, now if they ask you beta what are the surgical procedures, so yaad rakhna beta, in a case of chronic pancreatitis beta, we have to first see that the problem whether it is inside the duct beta or the tissue basically. Reason is, if the problem is inside the duct, that means whether the duct is not able to properly drain, then we have to go for a drainage procedure beta. But if the problem is inside the tissue, that means the tissues have undergone inflammation, fibrosis and necrosis beta, then we have to go for a resective procedure. Clear about? So if the problem is inside the duct beta, as I've told you, you have to go for a drainage procedure. Okay, so जब भी the problem is inside the duct, you have to go for a drainage procedure. If the pressure inside the main pancreatic duct is less than 6 millimeters of mercury, if the pressure in the main pancreatic duct is less than 6 millimeters of mercury beta, you have to go for what? You have to definitely decrease this pressure. And how this pressure is going to decrease? Obviously, sorry, less than 6 mm dilation. The pressure is high definitely, but it is less than 6 mm dilatation. So please remember, when the duct is less than 6 millimeter dilated, matlab the diameter of the duct is not too much. Okay, so if the duct is less than 6 millimeter dilated beta, now why the duct has undergone dilatation? The duct has undergone dilatation beta, the pressure in the duct is high because the duct was not able to drain the secretions properly. Now if we want the duct to drain all the secretions properly beta, what we have to do? We have to go for an ERCP. Once we do a ERCP beta at the level of the sphincters, we have to make cuts or we have to make incisions on the sphincters. Why? So that the sphincters are able to relax and the opening which is there beta, it opens up wide properly. And if that opening which is there beta, it is going to widen up, obviously all the secretions which have been collected inside the main pancreatic duct will be able to drain properly beta, and then definitely the patient's condition which is there, it will get resolved. Okay, so in this procedure, when we make cuts over the sphincters beta to relax them, is called as sphincterotomy. So when the duct of the patient is less than 6 millimeter dilated, then please remember the surgery of choice in this patient has to be a ERCP with sphincterotomy. Then the procedure of the patient that we are going to perform is going to be a ERCP with sphincterotomy. No issues with this. But when beta, the duct of the patient which is there, okay, when the duct of the patient is going to be more than 6 mm dilated, when the duct of the patient is more than equal to, you can remember, okay, so when the duct of the patient is more than equal to 6 mm dilated beta, in that condition we have to go for a drainage procedure only. But this time beta, the drainage procedure will not only happen by a sphincterotomy. तो क्या करना पड़ेगा? We have to open the main pancreatic duct into the intestine properly. Why? Because if you open the main pancreatic duct into the intestine properly beta, then it will be able to properly drain its secretions beta. That is the reason you have to do this. Now there are two ways beta to open it up. Consider the white one which is there beta, it is nothing else but your jejunum, for example, intestine. And this black one that you're able to see beta is nothing else but your main pancreatic duct. Now the pressure inside the main pancreatic duct is very high. It is too much dilated because of retention of secretions, collection of secretions inside it. If you want to decrease the pressure and if you want to drain the secretions of the main pancreatic duct, you have to open it up into the jejunum of the patient. Why? So that as you open it up into the jejunum, all the secretions inside this are able to properly drain into the jejunum and the pressure inside this duct is able to decrease. तो उसके लिए दो रास्ते बेटा. One is an end-to-end connection. Okay, this is called as an end-to-end anastomosis or an end-to-end pancreaticojejunostomy. Now this end-to-end pancreaticojejunostomy that we do beta is classically called as the Duval's surgery or the Duval's procedure. Next important option is this one beta. When you are going to open up the main pancreatic duct into the jejunum beta, but this time it is a side-to-side anastomosis beta. And this side-to-side anastomosis is known as a side-to-side or a longitudinal pancreaticojejunostomy. And this longitudinal pancreaticojejunostomy that we have performed is known as a Pustow's surgery or a Pustow's procedure beta. Clear hai baat? So that has to be remembered. You can see over here in the picture beta. Okay, the first one is an end-to-end anastomosis beta, and this end-to-end anastomosis is classically called as a Duval surgery, and the side-to-side anastomosis beta, as you are able to see, this longitudinal or side-to-side anastomosis is known as a Pustow's surgery. which is ठीक है, यहाँ पे लिख लो, if the duct is more than equal to 6 mm dilated, we go for a pancreaticojejunostomy. First one is the end-to-end anastomosis, and that end-to-end anastomosis is known as a Duval's pancreaticojejunostomy or a Duval's surgery beta. It is known as a Duval's pancreaticojejunostomy or a Duval surgery beta. Whereas if they ask you that if it is side-to-side side-to-side anastomosis is known as a Postov surgery beta, or a Postov's pancreaticojejunostomy basically. ठीक है, याद रखना Postov surgery, and this is a longitudinal pancreaticojejunostomy. This is going to be a longitudinal pancreaticojejunostomy. Clear है बात? Hopefully that's clear to all of you now. No issues with this, anybody? Okay, hopefully that's clear to all of you now. Okay, done. Now if I talk about beta, if the problem is inside the pancreatic tissue, okay, the problem is not inside the duct. Now basically duct के लिए problem था, तो we gone for drainage procedures. Now let's talk about if the problem is inside the pancreatic tissue, then what are we going to do? If the problem is inside the pancreatic tissue, I told you we have to go for resective procedure, where you have to resect beta, where we have to cut out some part of the pancreatic tissue which has got damaged basically, right? The first one is beta, a duodenum preserving, you don't have to cut out the duodenum, a duodenum preserving pancreatic head resection. So if the problem is in the head of the pancreas only, then we only go for removal of the head of pancreas. Can you see this part of the pancreas has been removed beta, right? And what we have done now, whatever are the remaining parts of the pancreas left, उसको किसको जोड़ देना बेटा? Jejunum को. We know that jejunum is free, so I can cut out the jejunum, I can pull the jejunum, perform a first end-to-end pancreaticojejunostomy over here. This also is another anastomosis if this part of pancreas has been left. And third, again jejunum to jejunum, that is jejunojejunostomy has to be done. Okay. Mainly two anastomosis तो पक्के है बेटा. One is a pancreaticojejunostomy and second is a jejunojejunostomy. And in this condition, you can see the head and the neck of the pancreas, which might have undergone damage beta, those have been resected over here. This procedure is known as a Bejer's surgery beta, or a Bejer's procedure. This one which is there in the picture beta is classically known as the Bejer's surgery or the Bejer's procedure beta. So duodenum preserving pancreatic head resection, if they ask you, is classically called as the Bejer's surgery or the Bejer's procedure. That has to be remembered. And last important beta, if they say that the necrosis or the fibrosis which is there beta, the damage is seen in the pancreatic tail. So you have to do a resection of the pancreatic tail bache, and that resection of the pancreatic tail which is there, it is usually done by what? So please remember, it is usually done, okay, by a distal pancreatectomy. That means you just have to remove the distal part of the pancreas beta, and you have to go for a distal pancreatectomy. No issues with this, anybody? So that has to be remembered. Done with this? Okay, so that was all about the management beta of chronic pancreatitis in a patient. Whether you have to see it is a problem in the duct, then drainage procedures. If there is a problem in the tissue, then resective procedures. Drainage procedures में less than 6 mm dilated duct, ERCP with sphincterotomy, more than equal to 6 mm dilated duct, a pancreaticojejunostomy. End to end is known as duals, side to side is known as pastos. The resective procedures में duodenum preserving pancreatic head resection known as the Bejer's surgery. Distal tail and distal body and the tail of pancreas removed is known as distal pancreatectomy. Now let's start with pancreatic cancer next beta. If I talk about pancreatic cancer now, so do remember what are the do remember what are going to be the risk factors of pancreatic cancer. तो याद रखना है बच्चे, the risk factors for pancreatic cancer are usually going to be just the risk factors for pancreatic cancer are usually going to be beta. The first one is going to be obesity. Okay, so obesity is important risk factor. Next is diabetes mellitus. So obesity, diabetes mellitus, hereditary pancreatitis. Okay, so if there is pancreatitis due to gene mutations beta, the patient will have pancreatitis on a recurrent basis, and that's the reason the patient will have an increased risk of pancreatic cancer as well. Next, if a patient having episode of chronic pancreatitis which remains untreated, and that may progress into a cancer later. Next condition is Peutz-Jeghers syndrome. Hopefully all of you remember that we have discussed in colorectal carcinoma that Peutz-Jeghers syndrome is a pre-malignant condition. It is due to the STK11 gene mutation on chromosome number 19, autosomal dominant pattern of inheritance. It has multiple jejunal hematomatous polyps. Therefore, it increases the risk of colorectal carcinoma. But I've told you the most common cancer that is associated with Peutz-Jeghers syndrome, जिसका risk is going to be 100 times higher than a normal individual, is going to be pancreatic cancer beta. Okay. Next is the BRCA2 gene mutation. Hopefully you remember that the BRCA2 or the BRCA2 gene mutation, I've told you, is associated with the male breast cancer as well as P cancers beta. P say one definitely was the prostate cancer in male, second was the pancreatic cancer, and definitely beta HNPCC, that is hereditary non-polyposis colorectal cancer, also known as Lynch syndrome, due to mismatch repair gene defect or the mismatch repair DNA defect, and FAP beta, familial adenomatous polyposis, which is due to APC gene mutation, also increases the risk of colorectal cancer. So HNPCC and FAP both can increase the risk of pancreatic cancer as well beta. If they ask you that what is going to be the most common gene mutation in pancreatic cancer beta, तो याद रखना है the most common gene mutation in the pancreatic cancer is also seen in the colorectal cancer. I hope all of you remember the gene mutation of colorectal cancer. What was that gene mutation? It was the KRAS beta. So here also the most common gene mutation in pancreatic cancer could be KRAS gene mutation beta. Apart from that, the other gene mutations can be P53 as usual, Sarkari gene in cancers, or next one which is there beta, it can be PRSS1. So PRSS1 or even SPINK for that matter is a gene. So these are the genes beta which are undergoing mutation in a case of a pancreatic cancer. KRAS being the most common one beta. So KRAS is associated with colon cancer and pancreatic cancer. But apart from that, even P53, PRSS1 and SPINK genes are the one beta which can be associated with the pancreatic cancer. That has to be remembered. No issues with this, anybody? Do remember that. If they ask you which is the most common type of a pancreatic cancer, I hope there is no issue in this because pancreas is a gland, and I hope all of you are quite aware that glands usually have a columnar epithelium for secretion. So therefore, the most common type of pancreatic cancer has to be an adenocarcinoma, right? So it has to be an adenocarcinoma beta. And usually, which kind of an adenocarcinoma beche? So please remember the most common site for the pancreatic cancer which is there. The most common site for a pancreatic cancer which is there beta, it is the duct basically. Yes, the main pancreatic duct is the most common site beta for the pancreatic cancer to develop. So ductal adenocarcinoma is going to be the most common one. The most common site, if they ask you beta, it is going to be the duct. याद रखना, ductal adenocarcinoma which is there, it is going to be very common. So duct is the most common site that you have to remember. And which part of the duct basically in the head, body or the tail? So याद रखना बेटा, it is duct basically but in the head region of the pancreas, right? It is mainly the duct of the pancreas but mainly in the head region of the pancreas is the most common site. Clear about? Now there is another cancer also beta in the pancreas which is called as a periampullary cancer. अब ये क्या होता है? Periampullary, peri means around beta. Okay, literally peri means around. तो इसका मतलब क्या? Understand. We know that your pancreatic duct which is there along with the common bile duct opens into the second part of duodenum beta at the ampulla of Vater basically. So this is the common bile duct beta. Okay, this is going to be the common bile duct. याद रखना ये बात. And this is going to be the main pancreatic duct. याद रखना, in this condition now, what can be the what is called as a periampullary cancer? Any cancer that is within the 2 centimeter range of the ampulla of Vater. I hope all of you are quite aware. The second part of duodenum where the CBD and the pancreatic duct opens up, that is known as ampulla of Vater. So any cancer beta within this 2 centimeter range of ampulla of Vater, that is what is called as a periampullary cancer. Periampullary cancer कहाँ हो सकता है? Understand. The periampullary cancer which is there beta, it can be seen in the common bile duct at this side. It can be seen in the main pancreatic duct at this side. It could be seen definitely beta at the ampulla of Vater into the duodenum as well, right? In any part basically in this region, that is what is called as a periampullary cancer. No issues with this, anybody? So याद रखना है बेटा, periampullary cancer is nothing else but it is a group of 4 cancers beta which are situated, okay, which are situated within the 2 centimeters range, which are situated within the 2 centimeter range beta of the ampullary opening. Hopefully that's clear to all of you now. Now what can be the clinical features in a patient of pancreatic cancer? So whichever pancreatic cancer the patient may be having, beta, some common clinical features. If I talk about first, if there is a pancreatic cancer beta inside the pancreas, whether it is inside the head of the pancreas beta, that means in the tissue of the pancreas, or it is in the duct of the pancreas, can I say the patient may have obstruction of the common bile duct? right? So whether it is in the head of the pancreas, from outside the pancreas, common bile duct will get compressed, and if there is a periampullary cancer, then the common bile duct opening will get blocked. Okay, so due to either of these reasons, beta, the bile will not be able to drain. And when the bile is not able to drain, beta, the patient is actually going to develop which kind of problems? Patient will have a progressive obstructive jaundice, beta, right? As the bile is not able to drain, the patients are going to have, beta, a progressive obstructive jaundice that has to be remembered. Next important is distended gallbladder. If I talk about, the patients will also have a distended gallbladder, beta. Okay, the patients are also going to have a distended gallbladder. Basically, reason is if the bile is not able to drain, all that bile is going to stay collected inside the gallbladder, and due to that, beta, the gallbladder is going to distend and dilate, and that is going to cause a distended gallbladder. Next, the patient may have a weight loss also, beta, right? Due to a cancer, the patient may have weight loss, that is known as cachexia, beta, that may develop as well. Next important, the patient may have abdominal pain as well. Okay, the patient is going to have an abdominal pain also, and the patient will have a migratory thrombophlebitis, beta. Okay, so please remember the patient is actually going to have a migratory thrombophlebitis, and याद रखना इसका नाम. If they say what is the migratory thrombophlebitis, thrombophlebitis is inflammation of the veins. This migratory thrombophlebitis which develops in a patient of pancreatic cancer, what it is called as? तो याद रखना, it is classically known as the Trousseau syndrome, beta. Then you have to remember it is classically known as the Trousseau syndrome. ठीक है, so याद रखना ये बात. It is classically known as the Trousseau syndrome. If they ask you what is the investigation of choice, beta, so do remember that the investigation of choice in a patient of a pancreatic cancer has to be a CECT abdomen. I've told you, beta, 4 cancers in your abdomen. That is whether it is a renal cell carcinoma, a hepatocellular carcinoma in the liver, a pancreatic carcinoma, or even a gallbladder carcinoma, beta. In all these conditions, the investigation is not a biopsy, beta. Reason, if you try to take a biopsy directly from the skin, what is going to happen? When you bring out this needle, beta, obviously there can be a risk of spread of this malignancy to all the abdominal organs, to the peritoneal cavity, and even definitely to the abdominal wall, beta. To prevent the spread of cancer during taking a biopsy, beta, we better not go for any kind of biopsy for these cancers. These cancers are investigated with the help of a CECT abdomen. So investigation of choice for all these cancers, beta, has to be a CECT abdomen. Why a contrast enhanced CT scan abdomen? Reason, we also have to see, beta, that exactly which are the organs that are involved in the cancer, first thing. Secondly, what is the blood supply of the cancer as well. Okay, so that has to be properly investigated. If they ask you what is the investigation of choice for staging, so I hope all of you are quite aware the investigation of choice for staging has to be, beta, a PET CT. Because when I say staging, I mean definitely the whole staging, beta, that is T and M staging. Agar M, that is distant metastasis, if you have to check, beta, you have to do a positron emission tomography, that is a PET scan. And for the local cancer, we have to go for a CT scan. So investigation of choice is CECT abdomen. But if they ask you investigation of choice for staging, then your answer has to be a PET CT, beta. Clear about? Chalo. Next important, if they ask you what is a tumor marker, important question of pathology as well, beta. I hope you are quite aware that the tumor marker for a pancreatic cancer is going to be, anybody? The tumor marker for pancreatic cancer and gallbladder cancer is going to be same. It is known as CA19-9. Very important to be remembered, beta. Followed by serum CEA, beta, that is carcinoembryonic antigen. You will be like, sir, CEA was a tumor marker for colorectal cancer. Yes, beta. So carcinoembryonic antigen can be a tumor marker for colorectal cancer as well as pancreatic cancer. But if they ask you which is the best tumor marker for pancreatic cancer, answer has to be CA19-9, beta, has to be remembered. Clear about? Now, if I talk about the basic differences between the two cancers, one is going to be the carcinoma head of pancreas, the second is going to be a periampullary cancer in the patient, beta. Now, the basic differences between both of them we have to remember properly. Reason why we have to remember, because they may present to us with similar kind of features. Now, first of all, beta, the red one that you are able to see is basically a carcinoma head of pancreas. Okay, the green one that you are able to see, bache, it is nothing else but periampullary cancer, right? Now, important is, beta, let's see the first one, that if I say the patient is having a carcinoma head of pancreas, here, as the cancer will grow in the head of the pancreas, it will start compressing the bile duct from outside. And when the bile duct starts getting compressed, the bile is not able to drain, leading to an obstructive or a post-hepatic jaundice. But this jaundice which is there, beta, it is going to start late, because initially it is not going to immediately cause an compression or obstruction, na? So there will be a late onset jaundice in this patient, first thing. Second, it will be progressive in nature. That means once the duct starts getting compressed by the cancer, it will get compressed and compressed further only, beta. Therefore, the jaundice of the patient will keep on increasing with time. That means it will be progressive in nature. And the patient will have a constant abdominal pain. But if I talk about a periampullary cancer, बच्चे, periampullary cancer में problem क्या होगा? Now understand. Here definitely the jaundice will be early onset, beta. Why early onset? Because here the cancer which is there, it is immediately at the opening of the bile duct. As the cancer is immediately at the opening of the bile duct itself, here it will immediately block the opening of the bile duct, and therefore the patient will not be able to drain the bile, causing stasis of bile, leading to obstructive or a post-hepatic jaundice. So in periampullary cancer, beta yaad rakhna, the jaundice will be early onset, first thing. But second, it will be intermittent. What is intermittent? It will keep on coming and going. That means waxing and waning course will be seen, beta. Sometimes jaundice will be seen, sometimes it will not be seen. Why? Reason, beta, this periampullary cancer grows in size, and when it becomes too heavy or too big in size, beta, it falls off. Yes, this mass falls off from here, beta. It bleeds away, right? That is important. So now definitely when the mass is going to fall off from here, beta, obviously now the common bile duct will be open. Now the bile will be able to drain, and now the patient will have no jaundice. Again after a few days, beta, the mass will start developing over here, causing an obstruction again at this side. Again the patient will have obstruction leading to a jaundice. So here the jaundice which is there, it is not going to be persistent or progressive like carcinoma head of pancreas. In periampullary cancer, the jaundice which is there, beta, it is going to be intermittent. It will show a waxing and a waning course, and therefore the patient will also have a colicky abdominal pain. ठीक है, तो याद रखना, if they ask you, beta, carcinoma head of pancreas में the jaundice which is there, I told you the jaundice is going to be late onset, beta, and second, it is going to be progressive nature. It is going to be progressive in nature. But if I talk about periampullary cancer, बच्चे, periampullary cancer में याद रखना बेटा, it is going to be an early onset jaundice, beta. It is going to be an early onset jaundice, and second, it is going to be intermittent in nature. It is going to be intermittent in nature. Next, abdominal pain if I talk about, तो याद रखना, abdominal pain in a patient of carcinoma head of pancreas is going to be constant, but abdominal pain in the case of periampullary cancer is going to be colic in nature, beta. Abdominal pain in a case of periampullary cancer is going to be colic in nature. Investigation of choice which is there, beta, in carcinoma head of pancreas is going to be CECT abdomen, beta. Investigation of choice in a carcinoma head of pancreas is going to be CECT abdomen, बच्चे. But the investigation of choice in periampullary cancer, beta, you can go for a ERCP with biopsy. You will say that sir आपने तो biopsy नहीं बोला था. Yes, I told you biopsy is now not recommended usually for a cancer which is inside the tissue of pancreas. But यहाँ पे in periampullary cancer, beta, the cancer is around the ampulla of Vater or around the ampullary opening. Can we take a biopsy without the risk of spread? Yes. How? We can go for a ERCP via the natural opening of mouth, and once you reach to the ampullary opening, from there you can easily pass a instrument and you can take a biopsy. Right here you are going to remove it from the natural opening, so risk of spread is not going to be seen over here. Okay, you are not invading some tissue, no? So that is the reason, beta, here you can go for a ERCP with biopsy. So याद रखना है अभी usually for a pancreatic carcinoma, if they ask you what is the investigation of choice, answer has to be straightforward, CECT abdomen. But if they say periampullary cancer, then the only type of pancreatic cancer, beta, where you can mark ERCP with biopsy as the investigation of choice is a periampullary cancer. Clear about that? Is important. Now important is, beta, this one. This investigation that you are able to see is nothing else but a barium meal follow through. Why I'm calling it as a barium meal follow through, बच्चे? Reason I'm able to see the barium inside the small intestine now, in the duodenum now. That's the reason I'm calling it as a barium meal follow through. And on that barium meal follow through, we are able to see a classical picture. And what is that? Here, as there is a carcinoma head of pancreas, beta, it is actually causing compression of the duodenum. And due to compression of the duodenum, beta, you are able to see a very classical feature. And this feature looks like what? Which alphabet? It looks like a E basically. Or we can even call it as a reverse 3, ulta 3 lag raha hai, right? So please remember, beta, in barium meal follow through, if you do in a patient of carcinoma head of pancreas, you may be able to see this E sign also called as the reverse 3 sign, or the best one beta you have to remember, it is basically known as the Frostberg sign beta. And this was a previous year question of FMG examination beta. So they asked the name of the sign, answer was a Frostberg sign. So yaad rakhna beta, either you can call it as the E sign, the reverse 3 sign, or the Frostberg sign beta, which is seen on the barium meal follow through in a patient of carcinoma head of pancreas. No issues with this, anybody? Now, next important if I talk about beta. Okay, next important if I talk about is the treatment in the patient now. Shall I? If they ask you beta, if there is carcinoma, hopefully you have written all of you. If they are saying beta, what is the management in a patient of pancreatic carcinoma? So yaad rakhna, if there is carcinoma in the body or the tail of pancreas, if there is a cancer in the body or tail of pancreas, we can just remove the body or the tail of pancreas beta. And removal of body or tail of pancreas is called as a distal pancreatectomy, right? The removal of the distal body and the tail of pancreas beta is going to be called as a distal pancreatectomy. No issues with this, anybody? That has to be remembered. Next important, if they ask you beta, that if there is a carcinoma head of pancreas, basically if there is a carcinoma head of pancreas, or even if there is a periampullary cancer, in this condition what is going to be the management or what is going to be the surgery beta? So yaad rakhna, if there is a carcinoma in the head of pancreas or in the periampullary region beta, is taraf agar koi cancer hai, so yaad rakhna, what are we going to do? We are going to perform this surgery. This picture was shown in your examination earlier in FMG previously, and they asked which surgery has been performed in this below given picture. ठीक है, तो याद रखना, if there is carcinoma in head of pancreas or in the periampullary region, this surgery is performed. क्या क्या निकाल रहे हैं उसमें? Understand, we are actually removing the head, the neck and even the uncinate process of pancreas. ठीक है, तो head and neck of the pancreas has been removed. Along with that, you are going to remove the duodenum, because duodenum can be commonly involved beta. We are also going to remove the pylorus if required of the stomach beta. We are also going to remove the common bile duct, the cystic duct and the gallbladder. All these organs are to be removed beta. Okay, so what are we removing in the surgery? You can write below this क्या क्या रिमूवल करते हैं अपन. ठीक है, तो what is removed basically in this surgery? We have to remove the head and neck of pancreas beta. We have to remove definitely the head and the neck of pancreas. Along with that beta, it is the duodenum that we are going to remove. Okay, we are going to remove the duodenum also. Next, we are also going to remove beta. Okay, we are also going to remove the common bile duct or the CBD. Okay, we are also going to remove the beta, the common bile duct or the CBD basically. We are also going to remove the gallbladder over here beta. Okay, plus minus pylorus it is basically. If pylorus is involved, we can remove the pylorus also. So head and neck of the pancreas, duodenum, common bile duct and gallbladder. These are the common organs which we have to remove at any condition beta. Okay. Now important is, apart from this beta, what are the three anastomosis that we are going to perform? So yaad rakhna hai bache, the three anastomosis that we are going to do basically are going to be the three anastomosis that we are going to do. After removal of all these structures beta, now whatever is left, we have to connect them. The first one is, we know that duodenum has been removed. So what is left now? Jejunum. You have to pull up the jejunum and you have to perform a first anastomosis with pancreas and the jejunum. This is the end to side anastomosis beta of the pancreas and jejunum. So this first one is known as a pancreatico-jejunostomy. Second is definitely, what if some part of the common bile duct is left beta? You can perform an anastomosis of the jejunum with the common bile duct. That can be called as a choledochojejunostomy. But usually we remove the complete common bile duct, and therefore it is the common hepatic duct which is left. So the second anastomosis is between the common hepatic duct and the jejunum. That will be called as a hepatico-jejunostomy beta. And third is definitely the stomach of the patient. Now pylorus has been excised somewhat, so it is the stomach of the patient beta which is going to be connected with the jejunum. That will definitely be called as the gastrojejunostomy. So the three types of anastomosis that we are going to perform in this surgery beta. याद रखना, there are three anastomosis which we are going to do over here in this surgery. The first anastomosis that I have told you is a PJ-stomy, that is a pancreatico-jejunostomy. The second anastomosis is a HJ, that is a hepatico-jejunostomy. And the third anastomosis is GJ, that is a gastrojejunostomy. These three anastomosis are going to be performed: pancreaticojejunostomy, hepaticojejunostomy, and a gastrojejunostomy. These three anastomosis after removal of all these structures, and this surgery together is classically known as the Whipple surgery. Beta, yaad rakhna hai, this surgery which is there is classically known as the Whipple surgery. So I hope all of you are quite aware now that the treatment for a pancreatic cancer, if it is in the head of pancreas or it is in the periampullary region of the pancreas, beta, it has to be the Whipple surgery. It has to be the Whipple surgery. Clear about? Hopefully that's clear to all of you now. So when the cancer is in the head or the periampullary region, pancreaticoduodenectomy is done, and this pancreaticoduodenectomy that we have performed is classically what is known as the Whipple surgery. Okay? Nowadays, beta, we thought that if we can save the pylorus, we can try to save the pylorus. Reason, beta, because there were patients who were having problems of impaired gastric emptying after pylorus removal, right? As in previous Whipples, beta, we used to remove the pylorus, na? Therefore, the food was not able to empty properly from the stomach into the duodenum. So there were problems of gastric emptying, beta, which is the most common complication after Whipple surgery. So nowadays, beta, we have come up with a pylorus preserving Whipple's procedure, and this pylorus preserving modified Whipple surgery that is performed nowadays is known as a Longmire and a Traverso surgery, beta. It is classically called as the Longmire and a Traverso surgery. It is a pylorus preserving modified Whipples. That can also be done now, Longmire and a Traverso surgery. Clear about? Still Whipples are more commonly done. Even if we call Longmire and Traverso, it is nothing else but a modified Whipples only, na? So that is important. So if they ask you what can be the complications of Whipple surgery, to yaad rakhna hai beta, complication of Whipple surgery are going to be, if they ask you most common complication, as I've told you, impaired gastric emptying, beta. Either you remove the pylorus or you damage the pylorus, due to which, beta, the patient will have difficulty in gastric emptying. So there can be stasis of food into the stomach. So impaired gastric emptying is going to be the most common complication, beta, after Whipple surgery. If they ask you that which is the most common cause of death, to yaad rakhna, after Whipple surgery, if they ask you what is the most common cause of death, then your answer has to be, beta. Anybody? Then your answer has to be anastomotic leak. Reason, so many anastomosis we have performed, na? So definitely there can be anastomotic leak, and I hope all of you are quite aware. If there is an anastomotic leak, beta, after the Whipples, these enzymes or these secretions are going to leak out into the peritoneum, and they are going to cause severe inflammation of the peritoneum, beta, leading to peritonitis. So due to that anastomotic leak, the patient may develop peritonitis, and that will be the cause of death of the patient, beta. Clear about? So most common cause of death, if they ask you, answer has to be anastomotic leak, which can lead to peritonitis and sepsis in the patient. Clear? So that was all about the management in a case of a pancreatic cancer, beta. Now let's talk about the case of let's talk about the last topic in pancreas, and that is known as neuroendocrine tumors of pancreas. If I talk about the neuroendocrine tumors of pancreas, beta, okay, if I talk about the neuroendocrine tumor of pancreas now, one by one. The first important one-liners you have to remember, beta. Neuroendocrine matlab kya? I've told you that the tumor which arises from a cells which are going to secrete hormone, or the tumor which secretes a hormone or a neurotransmitter like substance, is known as neuroendocrine tumor. The neuroendocrine tumor of pancreas will usually arise from all the cells of the isolates of Langerhans, because those cells of isolates of Langerhans, the alpha, beta, delta and F cells, they are known to produce a hormone, right? So if they ask you which is the most common neuroendocrine tumor of pancreas, beta, so yaad rakhna hai, most common neuroendocrine tumor of pancreas, answer is a PPoma. What is a PPoma? It is a non-functional, okay, it is a non-functional pancreatic polypeptide tumor. It is a non-functional pancreatic polypeptide tumor, beta. So in this tumor, there will be overproduction of pancreatic polypeptide, but that is not going to be functional. Basically, no problems are going to happen. That is known as a PPoma. So yaad rakhna, what is the most common neuroendocrine tumor of pancreas? Answer is a non-functional pancreatic polypeptide tumor known as PPoma. But if they ask you which is the functional one, then so yaad rakhna hai, the most common functional neuroendocrine tumor of pancreas, most common functional neuroendocrine tumor of pancreas arises from the beta cells of pancreas. I hope all of you are quite aware that you know that beta cells of pancreas are known to secrete insulin. Therefore, the tumor is going to be called as insulinoma. The most common functional neuroendocrine tumor of pancreas is going to be an insulinoma, beta. Last one, if they ask you that which is the most common functional malignant neuroendocrine tumor, reason almost all cases of insulinoma are going to be benign, beta. Very few cases, very rare that insulinoma can be malignant. That's the reason, beta. Most common functional malignant neuroendocrine tumor of pancreas agar पूछ ले beta, then your answer has to be a tumor from the G cells of the pancreas. And I hope all of you are quite aware, G cell tumor is going to be called as a gastrinoma because it will secrete excess gastrin. ठीक है, तो the most common neuroendocrine tumor of pancreas अगर पूछे तो आंसर is PPOMA. Most common functional neuroendocrine tumor of pancreas अगर पूछे तो आंसर is an insulinoma. Most common malignant functional neuroendocrine tumor of pancreas पूछे तो आंसर is a gastrinoma. Now no issues with this anybody? People are confused usually with this. I'm not sure why, but basically yeah, this is the problem that they have most of the times. They are not sure which has to be answered. So hopefully now these three statements will make it very clear. Next important beta, if they ask you, first one is insulinoma. Now if I talk about insulinoma beta, we know that majority cases of insulinoma are going to be benign in nature beta. As I've told you, majority cases are benign, very rarely malignant beta. And you have to remember that it arises from which cells of pancreas? We know it arises from the beta cells of pancreas beta. It arises from the beta cells of islets of Langerhans, you can say, or beta cells of pancreas, you can say. If they ask you what is the clinical feature in the patient, so do remember, clinical feature in a patient of insulinoma beta is classically known by a triad, and that classical triad of insulinoma is known as the Whipple's triad beta. Yes, okay, yaad rakhna hai, Whipple's triad which is there, it is basically a triad seen in patients of insulinoma. Okay, so Whipple's triad will be seen. What are the three features of Whipple's triad now? Let's see one by one. First one, the patient is going to have fasting hypoglycemia. Reason? See, normally kya hota hai beta, during fasting, as the blood glucose levels are low, therefore the insulin secretion is going to stop. But if the patient is having an insulinoma beta, even during fasting, the insulin levels are going to be high, and that's the reason beta, the blood glucose level of the patient is going to fall severely in cases of fasting beta. So the patient will have a fasting hypoglycemia which will be very severe. Next important beta, blood glucose levels of the patient will be less than 40 milligrams per deciliter, right? As the patient is having excess insulin, the patient will develop hypoglycemia. That's the reason the blood glucose levels of the patient will be low, less than 40 milligrams per deciliter. And third, the patient will have resolution of symptoms beta. All these hypoglycemic symptoms like headache, tachycardia, palpitations, dizziness, sweating, all of these are going to resolve beta as soon as you give glucose to the patient. Reason is, if I give glucose to the patients beta, the patient's hypoglycemic symptom is going, hypoglycemic status is going to improve, and the patient will have resolution of symptoms. So what is the classical triad of insulinoma known as Whipple's triad beta? First, definitely fasting hypoglycemia. Second, blood glucose levels less than 40 milligrams per deciliter. And third, resolution of symptoms on giving glucose. Now, if they ask you beta, what is the diagnosis done by? So gold standard investigation, if they ask you beta, gold standard investigation to make a diagnosis of insulinoma, answer has to be fasting serum insulin levels beta. Yes, answer has to be fasting serum insulin levels. That means during fasting you have to take the serum insulin levels. I hope all of you are quite aware, as I've told you now, that during fasting definitely the serum insulin levels of the patient should be low. But here beta, even during fasting the serum insulin levels of the patient are going to be high, and that proves my diagnosis beta. If the fasting serum insulin level is going to be high, obviously that proves a diagnosis of insulinoma in a patient. Okay, normally during fasting insulin levels should be low. Or beta, we can also check for an insulin by glucagon ratio. Okay, if this is not an option, basically beta, if this is not an option beta, yaad rakhna ye baat ki, or we can also check for the insulin by glucagon ratio, and if that insulin by glucagon ratio is more than 0.4, if that insulin by glucagon ratio is more than 0.4 beta, that is what is diagnostic. Okay, that is what is diagnostic of insulinoma in a patient. Clear about that? Has to be remembered. Reason, if the insulin by glucagon ratio during fasting is high, more than 0.4, that is suggested the insulin levels in the patient are high. Clear about? Now if they ask you beta, that what is the best investigation for localization of the tumor, tumor exactly hai kahan pe? So if you have to localize that beta, the best investigation for localization of tumor is what? You have to pass the ultrasound probe into the patient's esophagus beta along with an endoscope. Now when the endoscope which is there and the ultrasound probe which is there, beta, it goes up to the second part of duodenum, it can easily see, beta, through the duodenal wall into the pancreas, and it will be able to pick up that small tumor also, beta. So definitely it is nothing else but an endoscopic ultrasound. If they ask you what is the investigation of choice for localization of the tumor, answer is an endoscopic ultrasound. If they ask you what is the drug of choice in the patient, I hope all of you are quite aware, beta, that the drug of choice in a case of insulinoma is a drug which is actually known to decrease the secretion of insulin by the beta cells of pancreas, and that is classically known as diazoxide. याद रखना ये बात, ड्रग ऑफ चॉइस फॉर इंसुलिनोमा, इफ दे आस्क यू ड्रग ऑफ चॉइस फॉर इंसुलिनोमा नोन टू डिक्रीज इंसुलिन सिक्रीशन इज नोन एज डायजॉक्साइड, बेटा. ठीक है. नेक्स्ट इंपॉर्टेंट, व्हाट इज द डेफिनेटिव सर्जरी इफ दे आस्क यू. तो याद रखना बेटा, द डेफिनेटिव सर्जरी, ओके, इफ दे आस्क यू व्हाट इज द डेफिनेटिव सर्जरी इन द पेशेंट, the definitive surgery in the head of pancreas is going to be enucleation, beta. Definitive surgery in the head of the pancreas which is there, beta, it is going to be enucleation. That is only removal of the tumor, nothing else, because we know it is benign. So even a normal margin vagara is not required. You can just remove the tumor and that's more than enough. Next important, beta, if the tumor is in the body and the tail of pancreas, body and tail of pancreas may, if there is tumor, you can remove that distal part of the body and the tail of pancreas, called as a distal pancreatectomy again, right? You can go for a distal pancreatectomy. Clear to all of you now? That has to be remembered, beta. So enucleation or a distal pancreatectomy has to be done. Next important now, if I talk about, is known as a gastrinoma, also known as a Zollinger-Ellison syndrome, beta. The next important, if I talk about, is nothing else but a gastrinoma or a Zollinger-Ellison syndrome. Now, if I talk about a gastrinoma, bache, okay, if I talk about a gastrinoma or a Zollinger-Ellison syndrome, we have to remember one thing basically, that this gastrinoma or Zollinger-Ellison syndrome which is there, it arises from which cells? I've told you that gastrinoma which is there, it is a gastrin secreting tumor, and gastrin is always secreted by the cells known as the G cells, beta. So this gastrinoma which is there, it is actually going to arise from the G cells of the pancreas. Yes, you will be like, sir, G cells are not only seen in pancreas. Yes, G cells are not only seen in pancreas, they are also seen in the duodenum of the patient, also seen in the stomach of the patient as well. Yes, maximum gastrinomas are usually seen in the duodenum, but they may also be seen in the pancreas of the patient. Clear hai baat? So arises from the G cells of the pancreas, or I can say just G cells, you can remember. यहाँ पे pancreas की बात हो रही है, but we can talk about the gastrinomas as a whole diagnosis itself. ठीक है? So it can arise from the G cells. मोस्ट कॉमन साइट अगर वो पूछे बेटा, तो आंसर इज एज आई टोल्ड यू ड्यूडेनम, बेटा. बट कौन सा ट्राइंगल में, याद रखना ये बात, यूजुअली the most common site for gastrinoma is basically this triangle out here, beta. This triangle is classically called as the Passaro's triangle or the gastrinoma triangle itself. ठीक है. अब what are the borders of this triangle? Let's see at the junction of the cystic duct and the gallbladder, beta. From the junction of the cystic duct and the gallbladder, this is the first point. Second, definitely, beta, at the junction of the second and the third part of duodenum. At the junction of second and the third part of duodenum, this is the second point. Okay, so you definitely have to draw a line, beta, between both of them. Okay, you have to draw a line between both of them. Next, definitely, is a line, beta, which is actually going to dissect, or which is actually going to cut the second and third part of the duodenum. Okay, a line between the second and the third part of duodenum you have to draw, and then you have to connect both these points over here. This basically is called as the gastrinoma or the Passaro's triangle, beta. Clear hai? This is what is known as the gastrinoma or Passaro's triangle. In this triangle, definitely the risk of gastrinoma is going to be very, very high. Now here the cancer can be, okay, here the malignancy or the tumor can be in the pancreas, or it can be in the duodenum of the patient, or even in the distal part of the stomach as well. ठीक है? तो अगर वो मोस्ट कॉमन साइट बोलते हैं फॉर अ गैस्ट्रिनोमा और अ ज़ोलिंगर-एलिसन सिंड्रोम, आंसर हैज टू बी द पसारो ट्रायंगल और द गैस्ट्रिनोमा ट्रायंगल. आंसर हैज टू बी अ गैस्ट्रिनोमा और अ पसारो ट्रायंगल, बेटा. Hopefully that's clear to all of you now. Chalo, so that is important to be remembered. Now next important, if they ask you, is Passaro या gastrinoma triangle में most common site, as I've told you, it is the duodenum. Passaro या gastrinoma triangle में, if they ask you the most common site, answer is the duodenum. Now what is going to be the clinical features of the patient? Let's talk about them. We know, beta, that the clinical features of the patient can be abdominal pain, beta, or epigastric pain to be specific. The patient may have symptoms of dyspepsia, that is indigestion. Patient may have nausea, vomiting, bloating, all these kind of features beta. Patient may have diarrhea also, and the patient may have recurrent peptic ulcers beta. And these recurrent peptic ulcers which are there, okay, they can be definitely giant peptic ulcers beta. Okay, these can be giant peptic ulcers, or these can be multiple peptic ulcers as well. You will be like, sir, why? I hope all of you are quite aware about peptic ulcer disease we have discussed. I told you one of the risk factors is Zollinger-Ellison syndrome or gastrinoma. Reason, if the patient is going to have a tumor arising from the G cells beta or the gastrin secreting cells, definitely the patient is going to have elevated gastrin levels. There will be excessively high gastrin levels in the patient. And I hope all of you are quite aware that this gastrin which is there beta, it is going to stimulate the parietal cells, and as the gastrin is going to stimulate the parietal cells beta, that is actually going to increase the secretion of HCl, right? These parietal cells are going to cause more and more secretion of HCl which, and that's the reason the patient will have hyperchlorhydria, matlab excessive HCl levels will be there in the patient's stomach, and that's the reason the patient will have a recurrent peptic ulcers or giant or multiple peptic ulcers could be there. That is the important feature beta, yaad rakhna, that peptic ulcers will be seen in this patient which will be giant and multiple, and that is the reason for abdominal pain and dyspepsia of this patient. Clear about? Now if they ask you beta how to make a diagnosis, so please remember, overall the best test if they ask you, or overall the gold standard test which can confirm your diagnosis, is the serum gastrin levels beta. Yes, but how much? So if they say the serum gastrin levels of the patient are more than 1000 picogram per ml, if the serum gastrin levels of the patient are more than 1000 picogram per ml beta, that is what is a diagnostic feature in a patient of gastrinoma. If the serum gastrin levels of the patient are going to be more than 1000 picogram per ml beta, that is what is definitely a diagnostic feature of a gastrinoma or Zollinger-Ellison syndrome. Next important, if they ask you that what is going to be an investigation of choice for localization of the tumor, yaad rakhna, investigation of choice for localization of a gastrinoma is going to be a somatostatin receptor scintigraphy. You have to remember, it is going to be a somatostatin receptor scintigraphy beta. It's going to be the investigation of choice. Clear hai? So somatostatin receptor scintigraphy which is there beta is basically going to be the investigation of choice in this patient for localization of the tumor. No issues with this? Chalo. Done with this? Hopefully that's clear to all of you now. Next important beta if I talk about, and that is what is the drug of choice now. Okay, if I talk about what is going to be the drug of choice basically, so yaad rakhna beta, we know that peptic ulcers or hyperchlorhydria is the main problem, so you have to decrease the HCl secretion. We know to decrease the HCl secretion beta, the drug of choice has to be PPIs, that is proton pump inhibitors. So if they ask you what is the drug of choice, the drug of choice for gastrinoma beta has to be proton pump inhibitors or your prazole group of drugs which are there na, that is omeprazole, lansoprazole, pantoprazole. All of these proton pump inhibitors could be the drug of choice for a case of a gastrinoma. That has to be remembered. Okay, so drug of choice for insulinoma, I've told you it is diazoxide. For a gastrinoma it is PPIs, and we can even go for a surgery beta for removal of the tumor, and that surgery which is there, it is a pylorus preserving Whipple's procedure. And I've told you pylorus preserving modified Whipple's procedure which is there is called as the Longmire and the Traverso surgery beta, that can be done in this patient. Reason, pylorus is very rare beta that it will be involved, so it is better to remove only the duodenum and the head of the pancreas beta along with the CBD. Okay, the pylorus preserving modified Whipple surgery or the Longmire and Traverso surgery could be done. Okay, that was all about your gastrinoma or the Zollinger-Ellison syndrome, that has to be remembered. No issues with this? Chalo. Next important if I talk about beta is going to be another neuroendocrine tumor of pancreas, and that neuroendocrine tumor of pancreas is going to be glucagonoma beta. Okay, that neuroendocrine tumor of pancreas is going to be a glucagonoma. नाम से पता चल रहा है that this tumor is going to have excessive secretion of glucagon in the body. We know glucagon is secreted by the alpha cells of the pancreas, so this tumor arises from the alpha cells of the pancreas. So glucagonoma is also known as a hyperglycemic cutaneous syndrome. Reason, understand, as the patient is having elevated glucagon levels. Glucagon is known to increase the blood glucose levels of a patient. So therefore, the patient will have increased blood glucose levels leading to hyperglycemia or diabetes mellitus. Along with that, cutaneous syndrome beta, because the patient is going to have a skin or a dermatological manifestation in glucagonoma beta that we are going to talk about. It is very classical and rather the most common presentation also in the patient. Okay? And this, as I've told you, arises from the alpha cells of pancreas. This glucagonoma which is there beta, it arises from the alpha cells of the pancreas. That has to be remembered. First point. Next point, as I told you, 4Ds are going to be there beta. What are these 4Ds basically in a patient of glucagonoma or hyperglycemic cutaneous syndrome? First D is diabetes mellitus beta. Obviously, it is much evident that this patient is going to have high blood glucose levels. Second, the patient will have increased risk of DVT, deep venous thrombosis. Bache. Third, the patient will have a dermatitis, and this dermatitis or this cutaneous manifestation which is there, it is going to be this one beta. और ये picture क्या है? This is a very common similar picture has come in your examinations beta, or this condition has been asked in your examination a lot of times. Okay, in the recent 2021-2022 exams, even in 2023 NEET PG the question has come. This is classically called as a necrolytic migratory erythema. This manifestation of glucagonoma which is there beta, it is classically known as a necrolytic migratory erythema. Erythema means a red rash beta that you are able to see over here. Necrolytic means there will be necrosis in the center of this rash basically. Okay, as you're able to see. And definitely migratory matlab it will keep on changing the positions. So this is a very important thing beta. Just like you have remembered ulcers vagara na, pyoderma gangrenosum and all. Just like that, remember this very important topic beta in your recent pattern of examinations. Okay, necrolytic migratory erythema is associated with which tumor? Answer is glucagonoma, straightforward. Second, in one of the image based in one of the questions they have just given an image and asked you to identify that what condition is this and it is associated with which tumor. Okay. Third exam in the recent NEET PG the question was basically that necrolytic migratory erythema ka picture diya tha, and then they asked that this condition is more likely to be associated with a tumor from which among the following organs. So obviously the answer was pancreas basically, right? So that these kind of questions have come. I've told you 4Ds are associated with glucagonoma. One is diabetes mellitus, second is DVT, third is dermatitis. The fourth one is depression. Okay, these are the 4Ds beta which may be associated in patients of glucagonoma. If they ask you what is the investigation of choice, yaad rakhna, here also beta the investigation of choice you have to check for the serum glucagon levels. Again, if the serum glucagon levels of the patient are more than 1000 picogram per ml, if the serum glucagon levels of the patient are going to be more than 1000 picograms per ml definitely, then we can go for a confirmed diagnosis of glucagonoma in the patient. More than 1000 picograms per ml beta, if it is present, then obviously beta you have to remember, then a diagnosis of glucagonoma is much evident. If they ask you what is the treatment beta, so obviously here what we have to do initially though till the surgery that we perform beta, we have to manage the patient's diabetes by giving oral hypoglycemic agents which that is drugs like metformin or sulfonylureas. Along with that, or apart from that, we can also give insulin as well beta in the patient. Okay, the oral hypoglycemic agents or insulin or with insulin, whatever is required. And beta then finally we have to go for a definitive surgery, and that definitive surgery is nothing else but beta removal of this tumor basically. Okay, so surgical resection of this tumor has to be done. Ultimately, the surgical resection of this tumor has to be done, or surgical excision jo bhi bolna chaho. Lastly, if I talk about a VIPoma beta, what is a VIPoma? So yaad rakhna, VIPoma is basically a tumor which is going to secrete excess amount of VIP. What is VIP? Vasoactive intestinal polypeptide. So this tumor which is there which secretes excess amount of VIP is known as VIPoma. It arises from which cells of the pancreas? It arises from the F cells of the pancreas beta. I hope all of you are quite aware. Somatostatinoma will arise from the delta cells of the pancreas, and VIPoma will arise from the F cells of the pancreas. Yaad rakhna, in VIPoma beta, the patient is going to have the classical features, and they are remembered as WDHA syndrome beta. Now, what is basically a WDHA syndrome? WD stands for a watery diarrhea in the patient beta. And as the patient is going to have watery diarrhea beta, the patient will have increased risk of hypokalemia as well. And A stands for definitely the patient will have achlorhydria. Why achlorhydria? Because there will be loss of a lot of acid as well over here. Okay, and VIP is an inhibitory neurotransmitter. I hope all of you are quite aware, which stops the HCl secretion. That's the reason. So WDH syndrome will develop in this patients, that is WD for watery diarrhea, H for hypokalemia in the patient, and A for achlorhydria in the patient beta. These are the features that will be seen. Okay, so that was all about the neuroendocrine tumors of the pancreas in a nutshell. That is what is important from medicine and surgery point of view. Now let's talk about the next one, that is liver. Let's talk about liver now. If I talk about the liver beta, we know that liver basically is the largest gland of your body beta, right? We know liver is the largest gland of your body and it is approximately going to weigh how much? So please remember, it is the largest gland of body beta. It is approximately going to weigh somewhere between 1.4 to 1.8 kgs beta. It is going to weigh somewhere between 1.4 to 1.8 kgs. On an average, you can say 1.5, but the range is this much. We know that the liver is usually divided into how many lobes? It is divided into two lobes beta, the right and the left lobe. And we know that the liver is divided into the right and the left lobe beta based on a line basically, and that line is joining the inferior vena cava above to the gallbladder fossa below. अब यहाँ पे देख सकते हो, can you see this line over here beta? This line basically is joining the inferior vena cava above to the gallbladder fossa below beta. This line is dividing the liver into two lobes. The blue one that you are able to see is the right lobe of the liver, and the pink lobe that you are able to see is the left lobe of the liver. This is classically called as which line? The Cantley's line beta. Clear hai baat? So that has to be remembered if they ask you that the liver is divided into two lobes by which line. So the liver is divided into the right and the left lobe by a line joining the inferior vena cava and the gallbladder fossa, classically known as the Cantley's line. And this Cantley's line can also be called as beta. Okay, the Cantley's line which is there beta, it is also known as basically the cholecystocaval line. Cholecysto is nothing else but the gallbladder beta, okay, and vena cava. It is connecting both of them, so it can also be called as a cholecystovena cava line. So Cantley's line has to be remembered over here. No issues with this. Next important, if I talk about beta, is we know that the liver which is there, it is further subdivided into four sectors also beta. The liver is further subdivided into four sectors. The right lobe is further divided into the right posterior sector beta and the right anterior sector. Right lobe is further divided into the right posterior and right anterior sector, whereas the left lobe is further divided into the left medial and the left lateral sector. It is divided into the left medial and the left lateral sector. Clear hai baat? And lastly beta. Okay, so till now we have discussed liver is divided into two lobes by the Cantley's line. Further it is subdivided into four sectors beta. Now I am saying that liver is divided into 8 segments, and this was a previous year question that according to the Coynard's classification, liver is divided into how many segments? People mark 10. No, lung is divided into 10 segments beta. Liver is divided into 8 segments. That has to be remembered. Okay, so classification of the liver which is there beta, which divides it into 8 segments based on the arrangement of the hepatic veins and the portal vein. How the hepatic veins and the portal veins have been arranged basically, based on that, if I am going to classify the liver segments, it is known as the Coynard's classification. It is known as the Coynard's classification. No issues with this. So do remember that. Okay, so classification of the liver into 8 segments basically based on the hepatic veins and the portal vein distribution is known as the Coynard's classification beta. That has to be remembered. Can you see this lobe number 1 which is there beta? Lobe number 1 is exactly in the center of the liver beta. This is called as the caudate lobe. This lobe is special reason beta because it actually drains the bile into both the sides beta. That means it drains the bile basically into the right side as well as the left side beta. Second, it receives the blood from both the sides again. Okay, it receives the blood from the right as well as the left hepatic arteries beta. And lastly, it can drain the blood directly into the inferior vena cava. Yes, it does not drain the blood into the IVs, into the hepatic vein. It directly drains the blood into the inferior vena cava, and therefore it is a special lobe beta. Clear? That is lobe number 1 exactly in the center. It is not seen from outside. When you are going to open up the liver, then you are going to see it inside beta. Then in the left lobe of the liver, we have segment number 2, 3 and 4 beta. 4 is subdivided into 4A and 4B bache. Clear hai baat? Whereas the right lobe of the liver, which is there, that right lobe of the liver is going to have segment number 5 and 6, along with that segment number 7 and 8 beta. Clear hai? And below the segment number 5, basically we are going to have the gallbladder fossa, where the gallbladder of the patient is going to be located. Clear? Now if a patient is going to have beta gallbladder cancer, तो याद रखनी है बात that in patients of gallbladder cancer we have to remove the gallbladder. Along with that we have to remove the lymph nodes beta, the sentinel lymph nodes of gallbladder as well beta, okay, which are present in the Carrett's triangle. Alongside, definitely we also have to remove the lobes of the liver which are very close to the gallbladder, because those lobes of the liver can also get involved. And the lobes of the liver which are to be removed in a gallbladder cancer are these three beta mainly, right? It is the 4b, 5th and the 6th lobe beta. These segments of the liver have to be removed. Clear? So in gallbladder cancer, when we perform a radical cholecystectomy, and radical cholecystectomy beta has to be remembered that apart from the gallbladder and the lymph nodes, beta, we have to remove which segments of the liver? तो याद रख लो, we have to remove segment number 5, 6 and 4b. Okay, 4b I am writing last because it is plus minus, but 5 and 6 are to be removed always. Okay, so that's clear to all of you now. Next important, if they ask you beta, that segment number 4 is also known as what? So याद रखना, segment number 4 of the liver is also known as a quadrate lobe. Quadra means 4. So please remember, the segment number 4 of the liver is also known as a quadrate lobe. Whereas segment number 1 which is there, it is also known as a caudate lobe. Do not get confused. Segment number 1 is known as the caudate lobe. Okay? So segment number 1 of the liver is known as the caudate lobe, and it is a very special segment beta. So segment number 1 is known as caudate lobe, very special one. Reason, as I've told you beta, it has the arterial supply from both the sides, definitely, that is from the left as well as the right side. First thing to be remembered. Next important beta, it has a biliary drainage, that it can drain the bile basically beta, again in both the sides definitely. That means from the left as well as the right side it can drain the bile into. And third important beta, it drains the blood. Venous drainage is directly into the inferior vena cava, not into the hepatic veins. Clear to all of you? That's the reason caudate lobe of segment number 1 of liver is special. Next important beta, at the hilum basically. Okay, hilum, as I've told you, it is always a gate entry or the exit point beta. At the hilum of the liver pedicle which is there, na, that liver pedicle is basically a structure which contains your ducts and the vessels beta. So liver pedicle which is there, it is made up of one portal vein will be there, one common bile duct will be there beta, and one hepatic artery will be there. Okay. So now for example, if I say this is the portal vein of the patient, beta. Okay, just besides that we are going to have the hepatic artery. This is the portal vein. So here we are going to have the hepatic artery beta, and then we have to then we are going to have the bile duct. So please remember, at the hilum we are going to have the portal vein, the hepatic artery and the bile duct. It will give us a very classical appearance beta. And what is this appearance called as? So do remember, this is the classical Mickey Mouse appearance beta. Clear hai? So normally ultrasound, if it gives you a Mickey Mouse appearance of the abdomen, it is due to the presence of hepatic pedicle at the level of hilum of the liver. But Mickey Mouse appearance in the lower limbs on a duplex scan, I hope all of you are quite aware, it's seen in a saphenofemoral junction incompetence in patients of varicose veins beta. Okay, inshallah. Next important, now if they ask you beta about the Brisbane classification is generally used during liver resections, when we have to cut out some part of the liver beta. During that time basically we have to use the Brisbane classification. Now if I talk about liver resections, basically according to Brisbane classification, first one is when we have to remove segment number 2, 3, 4 and 4b. So if we have to cut out the segment number 2, 3, 4 and 4b, this should be called as obviously a left hepatectomy beta. Why? Because you are actually removing the left lobe of the liver, so you have to call it as a left hepatectomy. Same manner mein, if you are going to remove beta the segment number 5, 6, 7 and 8, then this will be called as a right hepatectomy, because you are removing the right lobe of the liver. That is known as a right hepatectomy. Okay. Next important beta, if I am going to say that the patient is removing, we are removing definitely beta the segment number 4, 5, 6 and 5, 6, 7 and 8 definitely, but along with that we are also removing the segment number 4. So matlab the segments totally removed are 4, 5, 6, 7, 8. if these segments are going to get removed beta, so it is a right hepatectomy, but it is extended, right? So it is called as a extended right hepatectomy, or we can call it as a right trisectorectomy, because we are removing three sectors beta. Okay, with three sectors, first is the right anterior, right posterior, and third is the left lateral sector beta. These are the three sectors to be removed. नेक्स्ट इंपॉर्टेंट अगर वो बोलते हैं बेटा इफ यू आर गोइंग टू रिमूव लोब नंबर 2 3 4 and 4b till here it was a left hepatectomy, but if I also remove beta segment number 5 and 8 in it, obviously then it is either called as a extended left hepatectomy, or we can also call it as a left trisectorectomy beta. Why it is called as a left trisectorectomy? Because we are removing three sectors. Which ones? The left medial and left lateral, along with the right posterior one as well. That is important. Clear है बात? Sure. So here beta, liver resections में we have to use the Brisbane classification. If we are removing segment number 2, 3, 4a and 4b, that is nothing else but called as a left hepatectomy. You'll be like, sir, if you're going to remove the liver, no problem, because liver is the only organ in the human body which has the capacity to regenerate. Next, removal of the lobe 5, 6, 7 and 8. Removal of segments 5, 6, 7 and 8 is known as right hepatectomy. Then removal of, definitely if they say beta, we have to remove lobe number 2, 3, 4a and 4b beta. We have to remove lobe number 2, 3, 4a, 4b and 5 and 8. This is called as a extended left hepatectomy. Either you can call it as the extended left hepatectomy, or we can call it as a left trisectorectomy beta. Next important, if they ask you beta, that removal of lobe number, segment number, if I talk about removal of segment number 4a, 4b, along with that 5, 6, 7 and 8, that is known as the extended right hepatectomy. Or we can even call it as a right trisectorectomy beta. We can also call it as a right trisectorectomy. Hopefully that's clear to all of you now. So do remember beta, these are the various types of liver resections according to the Brisbane classification that has to be remembered. Now let's talk about the next one, and that is about the liver infections and the liver abscess beta. There are two types of liver infections or liver abscess that we have to talk about. The first one, which is there beta, is going to be a pyogenic liver abscess, which is caused by bacteria, and second is going to be a amoebic liver abscess, which is caused by the entamoeba beta. Clear hai baat? Chalo. So if I talk about both the ones, the first one is pyogenic liver abscess. Before proceeding to anything, let's try to understand how does this pyogenic liver abscess occurs. So yaad rakhna, we know beta that inside the intestine we have a lot of intestinal bacteria. The most common one out of them beta, very common one, is going to be E. coli, right? So what happens? Okay, so let's take a break basically before starting liver infections, because the link is going to expire. So after the link is regenerated, then we can restart the session. Okay.